my, I don't know what these are called, actually, nameplate is Carolyn Downs, and I'm chairing the meeting this morning. And you're all very, very welcome. It's good to see you. The previous chair, Hugo Musca-Taylor, has now left and is no longer our chair, hence me just doing this. I am not the interim chair, I'm just chairing today's meeting. And the process to recruit a new chair for the board is ongoing and obviously will be completed once a new health minister is in place. So we hope that by the next meeting we might have a new chair, but if not, one of us will continue just to act as chair for the meeting. So on that basis, just to also say, the rheumatology service review has been advertised as starting the discussion at 11:15, and because it has been advertised as such, I think we'll probably get to that item before 11:15. But because it's been advertised at 11:15, I think we have to start it at 11:15 to be fair to people who might come for just specifically for that item. So if that is the case, we will just have to have a break. We'll probably have a comfort break anyway before that item, whatever. But just to say that we did wonder about what point we take that item, but it's been advertised at 11:15, so we're doing it at 11:15. All right then, so on that basis, we'll start the meeting more formally, and apologies. I have apologies from Simon Mackenzie and Jessie Marshall. Is there anybody else that you've got apologies from, Emma?
No, just to say, Chair, that we have on the screen both Bev Edgar, the Change Team HR and OD specialist, and Cathy Stone, the Chief Nurse from the Change Team. Both are on annual leave, but they've agreed to join us today, so thank you.
Well, thank you very much. So just so I say this so that people will hear it who doing the recording later, watching the recording later. That's Jessie Marshall, who's from the Change Team, and Beverly Edgar from the Change Team are both very kindly joining us when they're on annual leave. They're online. They're behind me, so both of you, if you want to speak, put your hand up, and Emma will alert us to the fact that your hand is up. I'd just like to ask before we start, do any members of the board have any declarations of interest? Nope. Okay, on that basis we'll move on to the minutes of the last meeting. Can people agree those minutes as an accurate record? Yeah? Yeah, okay. Right, and that, thank you very much for that. I'll go on to the action tracker in a second. Before we do that, I really need to say a welcome to Bill Nuttall. Bill, if you just kind of give everybody a twirl. Thank you very much. not literally. So Bill is the new interim director. So HR has been passed back to HCS to manage directly, as opposed to being managed within the government and state of Jersey. So Bill is doing that in the interim, whilst we sort out getting somebody on a permanent basis. And I think it's time for us to give a really grateful thanks to yourself, Steve, and to say to Steve Graham, I should say. Yes, to Steve Graham, who's going on to a bigger job actually in the states of Jersey with a wider remit than he's currently got. He did say to me yesterday he'll really miss HCS because it's in his blood. So thank you very much for all your help and support. Thanks, Steve. Right, so the action list, and anybody who's gone through all the papers will note that the action list is actually very long, the outstanding action list. And there's a lot of items on there where it just says a future meeting, a future agenda. So I've suggested to Emma that for future reference, rather than just saying future agenda, it actually says which agenda and when we're going to have those reports. So we've got a much clearer view of what the forward plan is, because otherwise things could just really drift. So Emma, rather than going through every single one now, Emma will do that for our next meeting. Emma, is there anything else you particularly wanted to highlight on the action list? Because there's a lot on today's agenda. There's a lot that's covered in Chris's report, but where I think we need a deeper discussion than Chris's report, that will only be highlighted as we go through Chris's report, or I've already said to Chris, we really need that to come back in more detail. Is there anything else you wanted to highlight, Emma?
Not from me. Yeah, I will add the dates of the future agenda. I do have those recorded, so it's easy enough to add on. And no, I think covering most of the items today.
Brilliant, thank you. And Chris, anything you wanted to highlight on future actions?
No. As I say, some of it I've covered briefly because we wanted to, recognising the rheumatology report, try to keep the agenda manageable. So I've briefly covered some of the things that are actions where we need to bring back a more detailed report, as you said, Chair, in at the next meeting.
Yeah, and actually because the States Assembly and the election today of a new Chief Minister, there are some items we've not been able to put in the public agenda today because we're in a period of purdah. So the agenda has been shortened somewhat from what it was going to be. Those items will just slip onto our next meeting. So it's not that they're not happening, it's just that they'll happen at the time which we're allowed to do it. So on that basis, I think we're actually on item 6, and looking at my timed agenda, we're already well ahead of where we should be. So it goes back to the previous point. So Chris, over to you. We've got a lot of time to pore over your report, just to warn you.
Right, yes, no, that's fine. I was going to take it as read, but I will go through and highlight some of the issues that I think really are important. And first of all, just to say the quality account, we published a quality account last year, is currently being drafted. That will be published in March, at the end of March. And for those of you that are not familiar with quality accounts, this is something that also happens in the National Health Service in the UK. And it's an account which will demonstrate our commitment to provide islanders with the best quality of service. It ensures transparency and openness about the quality of service, so nothing is hidden in those reports. And that will also help us identify the key quality objectives for this year will be included in that quality report. So that's something that will come to the board in March. From the point of view of the quality report within the agenda, as I say, we don't have Jessie Marshall with us, but Cathy Stone, I'm sure, can help us when we get to that particular item. But just to highlight a number of things. In December, we did see a marked decrease in the numbers of complaints, and during December, 28 complaints cases were closed. Avoidable harm for falls shows a continued reduction, which is very good news, but regrettably there have been an increase in the number of hospital-acquired pressure damage. Now, the tissue viability team continue to work alongside colleagues to provide education and training for staff and patients. We looked at this, and the data does not show that there's any one ward or any one area that has particularly high incidence of pressure damage, but there has been an increase, and that's mentioned in the more detailed report. There does remain a very clear focus on improving nutrition and hydration whilst in hospital to optimise patient recovery, and of course this also helps length of stay reduction. Clinical governance, again, you have on the agenda the serious incident position statement, and that will cover it in more detail. There's currently 40 serious incidents, SIs open, of which 28 are now overdue. During December, 9 SI were presented to the Serious Incident Review Panel, which meets weekly. 9 were closed with their recommendations accepted. 7 new SIs were declared in December of 2023. The HCS mortality strategy has now been completed and is now out for internal consultation with clinicians. And the care group governance meetings, which is a core component of improving governance across HCS, and the lead nurse meetings have now been running for 3 months and have demonstrated an increase in handler allocations, investigators to patient safety events, etc. One of the real challenges that we have in Jersey is being able to appoint investigators for SIs. So a good example, if it's a very specialist clinical area where we don't have the expertise on the island, we then have to look to other jurisdictions to find someone who can investigate that complaint, and unfortunately, as Patrick, our medical director, knows, that can take some time before we can secure an individual to undertake that investigation. So where we can do that internally, it's much quicker, but where we're dependent on
clinicians from elsewhere, and that does take longer than any of us would like. Okay. Maternity Improvement Plan, we've been reporting to this board since it was established, progress with the Maternity Improvement Plan, which was launched back in June of last year. Last month, progress includes a further 3 completed recommendations covering escalation processes for aggressive patients, ensuring a tidy and calm ward environment, and embedding of clear lines of communication, training and policies for postpartum hemorrhage and massive obstetric hemorrhage. A total of 87 now out of the 127 recommendations have been identified by the Women's and Children's Senior Leadership Team as complete, and you'll see there some of the recent progress in my report. Acute Medicine Improvement Plan, this was one of the actions. We will bring a more detailed report to the February board, but as the Chair said, we have been trying to reduce the size of the agenda today just because wanted to give appropriate and proper time to the rheumatology report. Work is being developed to establish a medical model that is something that we can sustain in Jersey, and that is being progressed through the senior leadership team. External expertise from a consultant physician has been incredibly useful, and as I say, that report will come to the board in February. Waiting lists, again, picked up by Claire Thompson later, but at the end of last year, 2023, progress had been made in reducing the waiting lists in some acute and community specialties. Diagnostics saw an improvement both in endoscopy, you'll see the numbers there in my report, with notable improvements in our MRI waiting times, which was a real focus for us. Community dental waiting list has reduced substantially from 1,897 to 532, and we are now starting to see reductions in both trauma and orthopaedics and ophthalmology. Inpatient outpatient activity was reduced in December, but that is what we would expect because of the bank holiday and Christmas period, but progress is being made. The real focus again for this board will be on implementing further plans to reduce our waiting times and waiting lists in Q1 of 2024, so I would expect this board to receive reports from Claire that shows further progress in reducing those waiting times. We are concerned a little bit about procurement capacity because that's critical to delivering some of the waiting list recovery plans we have for insourcing and outsourcing to ensure we have the capacity to make a real impact on our waiting times for islanders. And as I said, the board, I think, Chair, needs to remain very focused on that particular issue of performance. Another action from the minutes was about how we're going to improve our performance on infection prevention control as it relates to COVID and flu vaccinations for staff. It is our aspiration to increase uptake in 2024-25, and you'll see in the report some of the things that we're doing to try to see that happen. It is enormously important that this is improved. As regards to finance, we don't have a finance report this month. That's purely due to the fact that the Treasury processes that require the closing down of accounts, etc., and all the paraphernalia that goes with that for month 12 takes place during the course of this month. So we'll be bringing the finance report to the February board where we can have a detailed discussion. Medical job planning, we've received further advice from both the medical lead of the change team, Professor McKenzie, and from our HR resource experts advising the financial recovery plan following a significant concern over the quality and consistency of our existing job plans, and you'll see just a reference to that there. Clearly more progress, as Patrick Armstrong knows and Claire Thompson knows, is needed with the Chiefs of Service, the medical Chiefs of Service, to move job planning forward. There are particular issues with our job plans in Jersey around how the time in lieu aspect that reflects on core commitments is made, and there's discussions about how best we can move that forward. So a big piece of work necessary and continues into this year. Appraisal and revalidation of doctors, and indeed this is obviously not unconnected with and what we're seen in rheumatology a bit later on, that we had at the end of last year, the appraiser process was reviewed by the South West Higher Level Responsible Officer Group that are responsible for revalidation processes, and they made a number of recommendations which have been accepted by the senior leadership team, and in addition to the General Medical Council have requested that the role of responsible officer, and Patrick can explain if people are interested in what that role is, should become the direct responsibility of the medical director. It isn't at the moment in Jersey, and that is unusual. So from March 2024, the current responsible officer will step aside and hand over the role to the medical director, who will ensure the processes are in place. We are actively seeking external partner to support with appraisals in Jersey, and this will move to a system where we have a mix of internal and external appraisers for medical staff, and it's the intention of the GMC to audit the standard of our appraisals later in 2024. Cultural change, engagement and listening events have continued for all HCS staff. I've personally continued to meet many staff to discuss their particular experiences, and it says over the last month, but I've certainly been doing that since I started, and this enabled us working with the Freedom to Speak Up Guardian to tackle some of the issues that staff are experiencing. Aligned with the Be Heard survey, which of course is the government staff survey results, we're now focusing on the need for leadership and development across all levels of HCS, and this will be prioritised as a programme this year, and my colleagues and indeed myself will be attending a development programme in February of this year as a team that's been established by the Government of Jersey for all departments in the government. As part of the cultural change plan and the importance of strengthening behaviours of respect, kindness and kindness, a very well attended, thankfully, launch of a programme called Civility Saves Lives. Something if you type that into Google, you can see what that is, and that took place this month, and it was a very helpful start to that programme. In addition to the general launch, we have been targeting programmes of Civility Saves Lives to particular services that we have in HCS that have particular cultural challenges. Racial Equality Week across government starts on the 5th of February to the 11th, and we've been working very closely with staff from different backgrounds in HCS, and we're working towards being an anti-racist organisation in line with many other parts of the world to ensure that we care for our staff as well as deliver the best for Islanders. We're blessed by having that level of diversity in HCS, and we know that if racism exists, then ultimately, whilst those staff that are subject to racism suffer, also it builds and impacts on how they provide patient care, and that is obviously unacceptable. So this programme between February the 5th and the 11th will help us develop our anti-racist statement, and that will come to the board. I think, Cheryl, we're hoping that in February at the end, or maybe March, depending, because we need to collate the information. But diversity and inclusion plans are at the forefront of our 2024 programme, and we acknowledge the many cultures that contribute and enrich our workforce, as well as embedding that cultural change. This is something that we have to face up to in HCS and not brush under the carpet in any way, because this is too important for our staff and indeed our patients. So this will be a focus. We cannot pretend that racism does not exist within HCS, because with my meetings with some staff and listening to their stories, it clearly does. It may not be reported in the way that perhaps racist incidents between visitors or patients and staff is through the Datex, but it is present and we must tackle it. Workforce, well, a bit of good news. When you look back at 2023, we have successfully increased staff in post by over 200 full-time equivalents across all staff groups. That's largely clinical staff, nurses, doctors and allied health professions, so that is some good news. As expected, during December was a low activity month as regards to recruitment, so the vacancy rate has remained stable at around 16%. That is less than we were seeing a few months ago, so again, some progress there. And the voluntary turnover rate remains stable at just over 4%, which is actually incredibly low. So if you were to compare us with other jurisdictions, including the NHS, that is a very, very low. You would expect it to be 16%, maybe 18% in London, but 16% generally elsewhere, so a low turnover rate. There has been a slight increase in sickness absence, and if any of you are suffering with colds and flus and coughs, you might realise why during that period. Information on nurses and AHP recruitment pipeline is good news again, which indicates over 90 candidates for nurses and AHPs are in the clearance process or contract issue stage, and so likely to join and be with us now within the next 3 months. So that's clearly some positive news on the recruitment front. Statutory and mandatory training has been a topic for this board, and the new framework was agreed last year and is now being implemented. This is implementation with new staff. The more challenging task is ensuring all our current staff are up to date against the new framework, and it's recognised that this actually will take some months. We're talking 2,500 plus staff to go through that process. And you'll see here that some staff engagement and achievements are listed there. I won't read them out, so they're there to read. And just an update on the new healthcare facilities programme. Now, of course, that this is something that is obviously subject to other debates going in on other places. But the acute hospital is now at the concept design phase in December, and in January the clinical adjacencies in the proposed acute build have been tested across several clinical teams to ensure that they are happy with those adjacencies, and the feedback has been positive from those teams. The acute, what's known as the functional brief, has been approved by the clinical operation client group, with feedback from that group incorporated in that functional brief. Structured patient and staff questionnaires for those using the Enid Kenno Health and Wellbeing Centre are now underway, and we look forward to seeing what that says, and we'll see the outputs of that collated at the end of January, and these will be reported again, I'm hoping, for the February board, but if not March by the time we've collated it. So it'll be interesting to see how staff and our patients and visitors view that new facility. Demolition, for anyone that's been to look at Overdale, as I have, demolition is well underway, and formal arrangements are progressing regarding the lease of a facility which we've identified to house the rehabilitation service. The planning assumption is that this relocation takes place in March, maybe early April. There are some adjustments that we want to make around some infection control things, but generally that is moving forward. So end of March, early April, Samurai will be moving to that new facility. So I'll stop there, and as I say, some of these items are covered in more detail later, but just open up to questions.
Okay, Claire.
Thank you, and I'm really pleased.
Sorry, Claire, you just everybody just introduce themselves before they speak the first time.
I'm Claire Gerarder. I'm a non-executive director of Jersey Healthcare. I'm a GP and a psychiatrist by background. Yes, fabulous that things like the pressure sore rates are going down. I think that's really good. But I am struck that the time to first outpatient appointment is actually going up, with the numbers waiting more than 90 days. The graph is upwards. And also, I'd like to just briefly say what's been done about that. And also, I think the last time we were here, it wasn't access to MRI that was the issue. It was actually access to the MRI being reported on. And there was stories of people waiting months for a report. So it's one thing having the picture taken, but if it's then not being reported on and then being lost because it's been delayed, how's that being addressed?
Okay, Claire, do you want to pick up on those things?
Yeah, sure.
Covering your report.
So in terms of the outpatients, so happy to, I can obviously talk in more detail when we look at the QPR. In terms of the year-end position, obviously we did see particularly in the over 90 day, slight increase in terms of the percentage. That was impacted by two things: the fact that we had slightly higher referrals in October, so we were addressing those, and of course obviously some of the capacity that we lost in December. We have got good progress in some of those BAU specialties in terms of trauma and orthopaedics. So we had 150 reduced from the waiting list in that area in November, and similarly even in ophthalmology another 150 patients were removed from the waiting list. And of course we have much work that will impact, particularly as we go into Q1 of 2024 with the insourcing and outsourcing projects. So I'm really confident that as we pick up speed again from the December period of sort of lost days around the bank holiday, as we move into January, I can already see the outpatient number and those waiting over 90 days is reducing. And there'll be significant impact to that as we go into February and March with the insourcing, because we know the waiting list recovery schemes, particularly in diagnostics, where we're going to have 400 patients treated in the first quarter, and also within cataracts, which will also be particularly impacting our patients who've been waiting even longer than 90 days, unfortunately, but with removal of 500 patients in the first quarter, particularly in those areas. So although we have seen a bit of an impact at the end of last year, that's not to say that we haven't reduced significant numbers. Community dental, over 1,000 patients. So I think there's lots of real benefit to how people are experiencing healthcare, but obviously we'll evidence that as we go into the numbers. In terms of the MRI reporting, I haven't seen that as a particular incident, so I'm happy to, obviously there were complaints, etc., but as we've progressed, we haven't had any further issues, but I'm happy to go back and provide a bit more detail at the next board.
Thank you, Claire.
Tony.
Yeah, I'm Tony Hunter. I'm one of the independent non-exec directors. I'm a social worker by background. It's good to see, Chris, this emphasis on staff engagement and listening events and so on, really. Because whatever complexities we're facing around this table and in the executive, at the end of the day, it's the staff who are delivering day in, day out that we need to create the environment for success for. So it's good to see that, really. I'd quite like to see personally, purely for information, there's something, the Monday message and the Wednesday newsletter.
Yes, no,
What does WOW stand for, by the way? Must be a Wednesday in there.
Well, it's Wednesday.
Wednesday, yeah.
WOW is Wednesday.
So yeah, no, if as non-exec you're not sort of on the circulation list looking across at Sophie there, and we can absolutely add you to that. So yes, definitely.
Another quick point: looking outside the hospital to all our social care and the staff out there. It's good to hear Andy telling me yesterday that there's only one vacancy in social care. Correct, Andy?
There's one social work vacancy.
One social vacancy.
There's not waiting for someone to take up those. We've got in the social care group, we have some vacancies in the learning disability supported living service, but in social work and social care we have the one vacant post currently.
That's an amazing statistic.
A different picture to other places.
Yes, indeed, yeah. Yeah, thank you. I've got a few items which I'll indulge myself with now as chair, if that's okay, if everybody else has finished asking questions. So, I think there's quite a lot that we need to cover on clinical governance in both the SI report later on the agenda and indeed rheumatology, so I'll leave all of that until then. Just a comment that the VAX figures here are as good as any in London, actually. So I don't know what's going on with vaccination and stuff generally, but actually it's very low take-up everywhere, not just on the island, but also in the UK as well. So, and I think your figures are as good as it gets, actually. That doesn't mean that we should be complacent in any way, shape or form. We've really got to really push the issue of vaccination without a doubt. The area which I'm most concerned about is job planning. So we had a previous report from Simon Mackenzie, Dr. Simon Mackenzie, and indeed yourself, Patrick, about how important job planning is to the future clinical governance, good clinical governance on the island, undertaking serious incident reviews. And I would say as well, if we look at the rheumatology report, if people have got proper job plans, then everybody knows what they're doing, how much private practice they're doing, how much public practice they're doing, etc., etc. I'm very concerned, therefore, that this is being delayed. Now, I get the fact it's not perfect, but I don't think job planning, actually, from my experience, is perfect anywhere. But actually, everyone else does it, and every doctor has a job plan, because that's part of what is expected, and the BMA are very, very strong on the fact that this should be for every doctor as well. So I'm really, really concerned that, having told us less than 3 months ago that this was one of the most important things that we had to progress as a department, that we're now basically saying it's paused. So my question is, are you still committed to it as an executive, and will it happen? And two, when will it happen?
Well, speaking for the
Okay,
speaking for the executive, absolutely. And
Yeah.
but Patrick can explain where we're at and what we're now doing.
So I just reiterate what Chris has said. Yes, we are absolutely committed to it. A lot of job plans were done, but when they were being reviewed, it was the quality of them, the consistency of them across the board. Those are the issues that were being raised. We've specifically mentioned toil or time off in lieu, which is unique to Jersey in terms of how job planning is done, because what that means is people on high frequency but potentially low intensity on-call routers can have up to 3 PAs or 30% of their time as time off in lieu, and then when you add in admin, SBA time and all those things, when you actually get down to the amount of clinical work that somebody would have in a 10 PA job plan, it can be 30 or 40% of their overall job. And that makes it quite tricky. There is a willingness, and that really goes back to the consultant contract in Jersey, which I think is 2005 or 2004, and which was, I'm sure, fit for purpose at the time, but is no longer really fit for purpose for the type of care that we're trying to provide these days, in the way in which doctors work as well. So there's a commitment from the consultant body itself through the local negotiating committee. There's a commitment from SEB, there's a commitment from us to potentially look at how we can address all those concerns and renegotiate that contract. That's clearly not going to be done quickly, but I think there will be opportunities through the LNC to perhaps voluntarily work in a different way to try and help job planning progress.
So could I'll just come back to, so thank you very much for that. I do think the issue of toil is something that we knew about before we went into this process, and the fact that consultants had contracts which were no longer really modern in some respects, that go back to 2005, we must have known about as well. So I'm just, again, slightly concerned that we could have foreseen all of this and therefore gone ahead with it. Are there any, can I ask you, Chris, are there any other staff, not doctors and not consultants, in the whole of HCS who do not have agreed job plans?
Certainly, when it comes to actually job planning, the allied health professions have job plans. When it comes to nurses, they don't have job plans as such, but clearly every nurse has objectives and reviews, and as do non-clinical staff as well. So all the directors have objectives and they're reviewed. One of the challenges we've got is putting those reviews and recording everything we need to do on the new Government Connect system. But certainly, if you look at which is the vast majority of our staff, of course, are nurses and healthcare support workers. They all have and are very clear about expectations on what they do through their contract and through their objective setting process. So from a job plan where you spell out every sort of PA, that is very much a doctor thing, but we have done that with our allied health professions as well.
So it feels to me there's a little bit something unfair, therefore, that most staff do have agreed targets and have to deliver against them, but one group of staff don't. And I personally think that's a real fairness issue. And that doesn't create unity across the workforce either if there isn't fairness that is seen to apply to all, and I think that's quite divisive. So I've got concerns around the whole issue of how this leads to excellent clinical governance, but I've also got concerns about fairness in relation to it. So I'd like you to take that away and to think about it and consider it and to come back to us with a really robust action plan to our next meeting about how you're going to take this forward, because I know that in your heart of hearts you are committed to doing this, but some of the issues you've just referred to, like renegotiating contracts, will actually take forever and ever and ever. So we'll never get to the right place otherwise. So if you could go away, I presume there's a doctor's staff committee that you can discuss this with to try to get them on board and supportive. I can't believe that there isn't a single employee in HCS that doesn't agree with fairness.
No, I agree, and one of the reasons that it's been paused is because looking through those job plans that had been done, that lack of consistency or fairness, and it just shouldn't be that way. But it also opens us up to challenge if they're not consistent. And those are a lack of consistency not between one department and another, but potentially within the same department. And that's why Professor Mackenzie and our other colleagues from the FRP team came back and said, look, this is an issue. We also need more robust information about activities that people are doing. So those are the detail that lies behind the job planning. I think previously we'd said, well, doing perhaps what you were suggesting, trying to do it quickly. So we were just aiming to get a timetable out, but without having that detail of expectations of what staff are going to do. That's a real weakness, and certainly given the financial position that we're in, the other issue that Professor Mackenzie raised was value for money from the organisation point of view, to make sure, because what we'll find is potentially that in order to get all the clinical work that we need to do, there'll be a significant increase in PAs because the standard contract in Jersey is 10. That will obviously, there'll be a financial pressure around that, and given where we are, that's a challenge as well. So we need to make absolutely sure that we're getting value for money as well.
Yes, of course, Claire.
Just following on from that, I mean, do you have activity data against each? Because I don't know how much granularity you see, but I don't mean possibly on individual performance, but actually departmental. So, for example, I don't think I'm able to answer now, what is the outpatient activity? How many patients are seen per hour? How many patients are seen per hour in ED? What's the operating list? What's we picked it up last time as to the use of the operating theatres and the percentage of time that operations have been coming. Because what we've got here is percentages, but to actually get some real numbers, because then I think it becomes so, people on the island see that there are only one patient seen per hour, for example. I don't know what the figures are, but so tackling it from a different end to say what's the activity per department and whether that's going up or down, because I think it is. We picked this up last time with the orthopaedic waiting list, and clearly you've made some inroads into that, but I can understand the complexity of altering everybody's contract, and doctors are particularly powerful wherever they are, and they won't want to be working harder for less. But if we started to see activity, then you can start looking at shifting activity to other places that might be able to do it as well, if not better. Sorry, Claire, were you going to answer that?
So I can certainly. We have some of the information that we need, and theatres would be an area where, as an example, where we're getting much better data. Where it's weak, and you're quite right, having worked in the NHS myself, you go to your job planning meeting and you'll be told exactly how many patients you've seen, exactly how many operations that you've done, and we don't, and they've never had that granularity, and I think that's what we're working on to get, so that it informs the job planning. It will improve now that we have Maxims, because prior to Maxims, when we had the old system, you couldn't work out on an individual clinician basis what their activity was, where I think I'm correct in saying, Claire, that you're beginning to see that information. And that, you're quite right, that's very important. Again, to try and get the consistency of what clinicians are doing and what those expectations of people are.
And data drives performance, and though there will be a normal distribution, because some consultants might be seeing much, complex patients, but you should see a normal distribution, and if you see complete outliers, then you need to tackle that. But it's the data, so I'm pleased you've got data. What's that name of that system? Metix is in.
Maxims. It's the new patient administration system.
And then in time, I think that maybe not given with the name, but I think that should be something that should be made public. It's a tiny island, and we should be seeing that sort of data, that consultant X is doing 1 operation per hour, but consultant B is doing 5 operations per hour for the same procedure. I often wonder, clearly if you go into the private sector, the activity is much greater because there's more incentive to work faster, and we see that not just in Jersey but right across the board. So thank you.
Thank you. Yeah, Claire Thompson, Chief Operating Officer at Acute Services. Yeah, I suppose two points for me. We do have data, so we can see the amount of referrals, we can see demand at a specialty level, and through I suppose the last couple of months we've developed our theatre utilisation dashboard, and we do have that down to consultant level now. So that is all arming us to have the right discussions so that we can drive productivity and efficiency and address waiting list issues. I suppose we haven't been able to get to a point where we can really articulate the impact of the job planning that has been done. So I think as an organisation, we have had more job planning discussions, and we've learnt as we've done that. So obviously we've learnt that having more data at a granular level, particularly because we can say what we're doing with staff now and our demand, but again it's also about what do we want it to be, how do we want to evolve services, and having different levels of data around that will be really helpful to us. So I suppose we're embryonic in that stage, but in regards to the chiefs of service, obviously who have operational responsibility across the care groups, they are very committed to job planning. They are having more discussions. I think key's been the support that we've got from HR and medical staffing to get actually experts to sit alongside our chiefs of service and our clinical leads to support them, and actually we're now using our HR systems, our e-rostering to help them do that. So that activity is going on, and obviously we'll continue to do that alongside the longer term pieces of work, I think, around the contracts, etc.
But I think that is the missing part. I've been used to seeing consultant level information, as you were saying, Claire, about how many shoulders Mr. Armstrong does per year and how many theatre sessions therefore he needs, and does he need more theatre sessions if we're going to reduce the waiting list. That sort of patient or doctor level data hasn't been available, but it is going now with the new Maxims, the patient administration system. We are getting that information. And we will use that in not just job planning, but it helps inform individual clinicians. Most doctors want to know that information themselves. So with that new system, that aids not just job planning, but many other things we need to do.
Can I ask another?
Well, is yours on a similar issue, Obi? It's just that Obi had his hand up. So so we'll take Obi and then come back to Claire.
We'll be working closely with the team doing the job planning, and from a FRP perspective, we've been supporting it over the year. I think what I wanted to just build on what Patrick has said is that the reason behind the pause is because doing job planning is for the sake of it achieves nothing other than telling you that it's not very good and that people are suboptimally allocated because of what they're doing. What you do need is activity data and understand therefore what the demand coming through the door is, where is my capacity currently deployed, and then you allocate accordingly. That's what we're all saying. It is the dearth of that data and the systems available to this executive team that frustrate what the board quite likely would say, well, why don't you just get on and do it? It isn't as simple as that. No. It is, it should be, but it isn't. So it is about having the data to say, where is my demand coming from? How do I look at money to do so?
If I could just interject there, because I think the point I get that it is complicated, and I get that it's not as simple as that. But just to set the tone and the culture, to actually have something is better than having nothing. because actually it sets the tone that this is what our expectation is as managers. You know what we expect of you, and we should know what you are going to give back to us. It's about effectively a contract between employer and employee. And when you don't have that, relationships break down and mess happens, if I can use that expression. And I just think I'm not saying, you know, just I expect you all to do this and to be wizards and to make this easy, because it isn't. But I think what I am saying is just having something which is a contract of, you know, this is what we expect of you, this is what you should give back to us, and this is what we will do to protect you and to support you in your role. I think that is really important. So that's why I say come back next time with what you can do around that, because I think if we just say it's too complicated, it's too difficult, nothing will ever change.
Chair.
That may be not what you were saying, Obi.
Chair, absolutely not.
Yeah.
You wouldn't expect me to, so I could just finish.
Yeah.
I think it is important to set the context before one then comes in with the delivery, what you're going to do about it, because context is what this is all about. And that's the context. Now, of course, we need to do something about it with an approach. We've decided to take the common sense approach, which is what you were saying, Chair. We are going to get into just to say what is currently happening, so we know where it is. But be aware that will not be the perfect answer.
Yeah.
The only perfect answer comes when you have done your proper
Yeah.
activity planning. You have reallocated resources. So from the money point of view, I think the money will still show where we're at when we've done the job planning. And that's what I'm highlighting for the money point. The money only tells you what's going on in the guts of the organisation. Even when the board has got its job planning done, the money will still say, it's not good enough, because we wouldn't have allocated it properly. And then when the proper work is done, with proper activity, demand capacity, and then reallocation of resources, and then new job plans are done, that's when the money will say, now we've got a proper allocation of resources. All I'm saying is, doing that, even in the work we've done in the NHS, takes quite a bit of time. But I agree, we can't just sit there for this one doing nothing. We need a position now, but doing it for the sake of it is not worth doing. That's behind the pause. So just to assure the board, I'm supporting Patrick in what he's trying to do, which is that to support the board, the decision behind the pause, Professor Simon Mackenzie and I wrote a proposal together with Patrick on this, was there's no point doing job planning for the sake of it, just to tick a box. We need to do it properly.
We'll bring something back, Chair, to the next
Thank you. Yeah, Claire, did you want to come
Well,
in?
thank you, because it's picking up on that. What I would find useful, I don't want to very is real numbers. You know, how many people is the island of Jersey seeing in the emergency department per year or per day versus the number of headcounts you've got delivering that service? Because if then we find out what you're doing is seeing one patient per hour, because I don't know. I mean, I do know it for my own, you know, I do know it for the NHS. I know how many patients per hour are seen in our own surgery, in our urgent care centres, in our ED departments. And I know it off the top of my head. I just wonder whether those sort of figures are known. Because if you find that the number of patients per hour is 1.2 or 1.3 per head count, or 0.8, I don't know. But do you know those sort of figures?
Well, we obviously know the numbers of people that attend A&E.
So what is it per day,
And
approximately?
is it a day now?
I mean, you don't have to be exact, but it's these sort of things
Or
that,
per year?
as a
rather
board
than-
member, I can then get my head round to understand the productivity. Because at the moment you've got massive waits in A&E. I take the point that some of it's coming down, but you know, 70% of patients waiting for more than 10 hours. The average length of stay is nearly 3 hours. Now I can understand, you know, things move slowly, but this is where I think I'm picking up with Obi. It's productivity. Now that then, so it's both productivity and job plan, but once we get the productivity, we can then start to use that as material to go and say, listen, it's just not fair that only 0.8. I don't know what the numbers are, by the way, so I'm just picking these out of plucking them out.
I think we're all violently agreeing
Yeah, I agree.
you know, this is something that we're way behind where we should be, and certainly where the NHS is, the lack of data, the granular level that we need, and obviously a very old-fashioned contract, but those things have to be addressed. I think Anushka.
Yes, Anushka, please. Yeah.
Just one clarification. So, Claire, you just mentioned waiting times in ED over 10 hours. So that's 69 patients in December, not percentage.
Thank you. And by the way, I just looked on the internet. You saw 40,000 people in ED in
over the year. Yeah.
over the
Yeah,
years.
which is nice.
It's about 100 to 130 a day.
Yeah.
And
So one, and maybe not for here, but afterwards, it'd be nice to know what the head count per full-time equivalent is in ED. So what does that, how many do you say per day? 130 per day. What does that mean in terms of number of patients seen per hour per full-time equivalent? And those are the sort of things that would help me as a board member understand productivity and,
Yeah.
and also the people of Jersey to understand their value for money.
So
Okay.
that's an
Okay.
important thing, is
Yeah.
it's not 69%, it's 69 people. Yeah.
Okay, so I think that was, I hope you agree, Chris
Yeah.
and colleagues.
I think we all agree.
That was a helpful conversation.
Yeah.
I think what's really important is that we actually, what we are doing here in raising these issues and prodding is actually supporting you in where you started off and where you want to get to. So this is entirely meant to be a supportive conversation to get you and therefore us, and more importantly, the people of Jersey, to a place where all of this productivity is completely transparent, open, understood and fair. So I think that's what, I hope you don't feel we've been overly
No,
harsh
it's
in
very,
any way.
no, it's a very
Yeah.
important issue, from job planning to transparency to doctor productivity.
And on that basis, I think we will have that as a substantive item at our next meeting. That would be really helpful. So thank you very much to you all for that, and thank you for your patience while we dug into that as well.
And thank you for correcting me, 69 patients and 69%. Still a lot of patients.
Okay, all right. So we'll go on. We're just a little bit behind time, which is fine. Onto the quality and performance report, because actually we've just been discussing quality and performance as it happens, Claire. But over to you for anything you particularly wanted to highlight, rather than going through everything in the report.
Sure. Thank you, Chair. With the focus on ED, perhaps I'll start there and then we can, and I'll pick up. So obviously around the 69 patients. So I suppose as we go into winter, obviously we know that EDs do become a little bit busier, and obviously we've seen some element of that. Not so much in December, but certainly obviously as we started these early weeks in January, as we've seen some winter pressures. Sorry, I do apologise. Of course, is that better? Yes. Okay, thank you. In relation to the 69 patients, I suppose I'd draw the board's attention to our conversion rate. So obviously that stayed pretty steady at 16, 17, 18%. So although our ED is a little bit better, that will be because of patients, some who need to come in and some who obviously we can turn around either with minor illness, etc. So of the patients that are waiting in ED, they're not patients that are necessarily coming into ED. So some of those people are people that we are giving therapy to, some interventions, and who will also go home that day. So obviously it's actually telling you not just about how hot the hospital might be and about how we might be responding to demand, but also it tells you about the whole system of offer from Health and Community Services. So this is about how we can also respond to people, return people to home, and obviously provide an intervention. Obviously as you go into winter, that does tend to increase, and there will be some patients in ED who are waiting because of flow, and I have no doubt we'll have data that tells that story, particularly as we go into January. Particularly in December, we did see rises in some viruses, which again is absolutely what you would expect and what we plan for. But of course the impact that has is that we often have to wait for beds of the right gender to become available, and also cubicles, because we were seeing a rise particularly in flu A in December, and obviously a wave of COVID. So I just wanted to sort of draw that out, but clearly what we want to do is make sure that particularly with people who are being admitted, we can pull them swiftly into the hospital, and with the focus that we'll have shortly about the quality performance report and the metrics that we want to hold ourselves to account for as we go into next year. Although maybe the ED target in the NHS, where I have worked previously, has sometimes been a controversial metric, It can obviously also demonstrate how quickly you are placing people into an acute hospital bed, and obviously is very impactful in terms of patient experience. So one that we want to measure ourselves against and drive both safety, quality and operational performance. So and we'll be able to then describe that to the board, because that is the sort of important cohort of that. I suppose in terms of the time to triage, obviously, you know, our standard is 15. Is 11 minutes, but we can see that generally within 15 minutes everyone's been assessed, had that immediate triage. We do know that there is some staffing changes, so actually our performance around the arrival time to triage is sort of complex with how we're using our current staffing, the fact that some staff needed to be trained in best practice, so that's ongoing, and we'll see a change in that in terms of when we go into the first 3 months of this year. We are maintaining our performance in relation to how we evidence that we've commenced treatment, and that's good to see, and we've got some actions that are going to force that last amber, particularly around the treatment with majors P1, P2, P3, but again we've had good assurance from the clinical leads. That's because most of these patients are arriving either by ambulance, going straight into majors, and clearly we have the clinical staff that are responding to that patient need, so they are starting treatment at the same time as they're assessing. So that's in relation to ED. Obviously we know that we are doing a focused piece of work on ensuring that we get people home in the morning, and that's the golden patient work, which is again supporting length of stay reductions. What was the other? Sorry, our occupancy obviously at midnight, which we want to focus particularly on our acute bed base, so we'll be looking at in the new year. I suppose in terms of waiting lists, I gave some headlines, so I'm happy to take any other questions in relation to outpatients. We will be focused particularly, and we will see improvements in our elective day waiting list as we bring further 28 beds online by the opening of Plemont Ward, which has been refurbed, and that will be opening mid-February, and that will again allow us to have a better bed base for both our key care groups, medicine and surgery, which will impact our emergency flow and the quality metrics we've just been discussing, but also then ensure that we've got that bed base to then really start driving down our elective waiting list. So I think those are the headlines from me.
Thank you. Thanks for that, Claire. Has anybody got any specific questions? I mean, Claire, you did ask questions earlier, the questions you had. Any other questions?
I think it's just to say that the 28 beds, that should, I'm expecting that makes a difference. So the fact that we've been refurbing a ward, which was very important, bringing those beds online, and also the work, the insourcing and outsourcing work we're doing to increase the capacity that we've got to reduce those waiting lists. Now that obviously relies on the funding situation, but at the moment we're continuing to do that, but we also know that we have some financial challenges, and those financial challenges during the course of this year and us working with the Treasury, we need to look at the impact of what we need to make in the way of savings and what that might mean. So part of the sort of equation around financial planning is impact, of course, both quality and productivity. So we're very minded to and want to continue to invest in reducing waiting lists, but we know that we're in a very tough financial and position that we need to deliver on. But as I said in my report, focusing on reductions in waiting lists has got to be absolutely key for this board. Now, of course, waiting lists are not just in our acute services, and I think Andy will pick up on mental health a bit later on.
Yeah, I was actually going to raise the adult social care plan reviews, which are mentioned here, which actually are well off target. So I think it would be useful, Andy, if you could let us know how we're going to catch up on that, because they do need regular reviews, as you are aware. And the other point I was going to raise is well done on infection control, everybody, because actually infection control across the UK is really increasing, and quite worryingly so, and that isn't the case here. So a big well done on infection control. Kathy wants to come in, but I think Anushka wanted to as well. Did you? No, you don't. Okay. So, Kathy, would you like to come in? And then, Andy, if you could just respond to my question, if that's all right?
Good to do all of mental health and social care. If that's,
At the same time, yeah, cool.
Yeah.
Cool.
Kathy?
Kathy Stone, Chief Nurse Change. Thank you, Chairman. I really wanted to reinforce the comment you've just made about infection control, when we've seen in the last comments about how busy our hospital is and the activity flowing through currently, and also to recognise that infection control is everybody's business. It is not the microbiologist or the infection control team. It is all the nurses, all the doctors. It is all the porters that safely transfer our patients around our hospitals and our cleaners. So I think this actually identifies where we have a hospital working together to place the benefits of our patients. And really, it is a very strong position. And I think as Chair yourself and Claire that's working across the NHS, it is a position many of our fellow trusts would be very envious of.
Without a doubt. Andy,
thank you.
you could just pull this over to you a bit more, I think.
Thank you very much. So I'm Andy Beale, I'm Executive Director of Mental Health and Adult Social Care. So the issues in mental health are fundamentally unchanged, although you will note that on a couple of occasions we have some data issues this month, unusually, where we're not able to provide some information. We're working through those with the data analysts and we'll rectify those for next month. But that's particularly in relation to a number of referrals into services and our occupancy data in relation to acute adult mental health, where we found there's an issue with how that's being recorded. The issues relate to access to or access to psychological treatment. So the good news is that people are seen very quickly for their initial assessment. We're way under the 90-day target in the Jersey Talking Therapy Service. In fact, 98% of people are seen well within that time. The bad news is that 55% of people this month have waited longer than 18 weeks to be seen, which is our referral to treatment target. The other bit of the good news, to create a sandwich, is that 86% of people that are seen are showing significant reliable improvement over time. This is one of the few outcome measures that we report in terms of outcomes rather than process measures, and I think it's really important to name it. So whilst people are waiting longer than we would want them to for access to their treatments, and clearly that's triage, that's one of the reasons that we do the assessment very quickly, when they get into treatment it's working and people are getting good results. So that's the piece of work that relates to capacity and capacity within the team, and we are currently recruiting into a couple of roles. We have some applicants, so I'm hopeful that we might see some change. The other waiting issues for us are diagnostic waiting issues. So people are not waiting to be seen by mental health services in the way that they were 2 years ago. You'll see that we have very clear targets for crisis within 4 hours and routine referrals within 10 working days. I say in the report that we review the crisis information line by line each month. Actually, I'm pleased to report that the position was better in December than is reported here. That's another one of the data issues. So I think we're actually at 90% for December, but I'll confirm that next month. That's about how people enter onto the system and the things that the system pulls through. Essentially, we need staff to make sure we're putting the right date and the right time on the right form in the right place on the system to make sure that the information is accurate. And sometimes we have some challenges with that. The diagnostic issues, so the memory assessment service, the waiting time is deteriorating, and that's a real concern to us particularly. But we also have significant waiting still in ADHD and autism services for diagnosis. This is really simply a capacity issue. We have a finite amount of psychiatrists, and how we deploy the time of those psychiatrists needs to be carefully thought about. We're currently having a conversation in the leadership team in mental health services about will we move psychiatric capacity into the memory assessment service to support dealing with this waiting list. We have to acknowledge that if we do that, it will have an impact somewhere else. So we're working through what's the right thing to do. We've been trying to source additional clinical capacity for well over a year in relation to some of these issues, and I've just found to do so. So that's a particular issue, and we will have to make some pretty tough decisions, I think, about how we utilise our resource, and I want us to be transparent in relation to that. The other issue of concern in December for me relates to delayed transfers of care. So whilst delayed transfers of care have reduced and we've had a sustained reduction in the hospital, and that's particularly because of the work that's being done jointly between the hospital and community services, in mental health services we're starting to see a significant increase. So 17 of the 40 beds in December were occupied by people who didn't need to be in hospital but couldn't go out. There are two reasons for that. One of those, and a large amount of those figures, are people with dementia who come into the dementia assessment unit and then we can't find a community placement for them, often due to complex need, and that can take some time, and we have someone who has waited for 20 months for a placement to be found currently. The second issue is in relation to mainstream housing. We have quite a high number of people that come into mental health services and lose their housing at the point at which that happens. There are a couple of reasons for that, and one of those relates to the benefit system and how benefit is paid. If you're detained and admitted to hospital here, then your housing benefit ceases. So actually, of course, potentially people then lose their accommodation. We had this mental health strategic partnership that yesterday met, and we've set 4 system objectives for mental health. So not HCS objectives, but system objectives for mental health next year. And one of those is to do a specific piece of work around housing and the creation of no fixed abode, and try to find ways jointly with our colleagues across government to resolve that. So I think that's really important. So sometimes people will just end up stuck in the inpatient unit because we can't put them in. Finally, in relation to social care, I'm really pleased to see that at last we have cracked the percentage of clients with a physical health check in our learning disability services, and that appears to be sustained. I held my breath when I looked at the December data, but it is sustained, it's improved. So that's really good news, I think, and you know, congratulations to the team, because they've done a lot of work on that to get over that 80% hurdle. The percentage of support plans reviewed, so we've rehearsed this once before. This is a technical issue that we are under the target, not a practice issue. This is recorded from the point at which the support plan is agreed to 6 weeks later. The difficulty is we have a really high percentage of cases where the support plan is agreed but isn't implemented until week 4 or week 5. So, for example, someone is in hospital, the support plan is agreed, but it takes a couple of weeks to find the provider that's going to deliver the community intervention. So actually, the clock starts at the point at which the plan is agreed, not at the point at which the plan is implemented. So we're doing a piece of technical work at the moment, looking at how can we report this differently, because I think it does a disservice to the practitioners. Okay. They're often agreeing the plan, but they're not going to go and do a review in week 1 if it's taken 5 weeks for it to be implemented. So so we are looking at all of our social care indicators, and Tony and I have talked about this on a number of occasions. But this particular indicator, we're looking at how can we report this differently.
Fair enough. Thank you. Right. I think at that point, Claire, final question from Claire, and then we'll move on.
Just a quick one. Andy, when you talk about neurodevelopmental, are you talking about children or adults?
Adults.
Okay. Then, I mean, I share your pain. I mean, the waiting time for neurodevelopmental assessments and treatment is across the world has rapidly increased. And you said, how do you ration it? That's what behind it. And I think versus, if I understood, if you take resource from one department to put it into the neurodevice, you're removing it from a department. So I think that is an important issue that you're going to have to struggle with. My feeling is you have to work on where will the greatest impact be, and having a diagnosis of ADHD at the age of 45 is possibly not going to have a massive impact on your life. You might possibly like to have the diagnosis, but whereas removing money from the memory clinic and finding out somebody's got early dementia will have a massive impact. So we're here to help with you. And before I go off this, I've been hearing sort of tales of trying to deal with this by recruiting GPs to do shared care for adult ADHD. I would urge way against that, because what my experience is, it will end up with the GPs, even if you pay them, having to prescribe very powerful medicines, not being reviewed by secondary care, by the specialist, because there just won't be the capacity to do that. And I think you would get an enormous demand with very little control. It doesn't mean you can't have a GP with a psychiatrist working together on the island, developing some sort of service in a different model. But I would urge against a blanket requirement for GPs right across the island to be taking on this care because you want to meet a waiting list. It will add to your costs. We've seen some of the prescribings we're going to discuss later. It could cause serious problems. So, here to help you as a board to come to these sort of decisions, because there is a difficult rationing decisions.
Thank you. The shared care issue. Thank you. We have developed a joint protocol with primary care in relation to shared care, which addresses the issues that you raise around very clearly an annual review by the initiation always by the specialist and an annual review by the specialist. pragmatically, we have one consultant psychiatrist currently who is doing all of the diagnosis and all of the prescribing for adults with ADHD. So he is prescribing for over 700 patients, as well as doing
what's the percentage of people referred versus the percentage that end up in the diagnosis? Because this is, again, it might be something that we discuss separately, but nowhere else do you get a sort of 90 to 95% diagnosis of a condition that the GP refers to, except in ADHD. In other words, you might as well just fill in the questionnaire and say, I've got it, because, so it's an issue that we might need to discuss further. But if you've got a GP, a doctor, looking after 700 patients, this is going to cause some problems, because but you cannot push that to another group of doctors and say, well, this is what's happening. I think it's about a debate at board level as to what we're going to do about it, because if these are prescribing serious drugs to serious people, then this is a serious issue.
And it's a systemic issue for us, because 80% of CAM's activity currently is neurodevelopmental. So actually we know there are a large number of children and adolescents who will be migrating into adult services. So I think I entirely agree with you, Claire. I think this is something that would be worth a paper, and I think it would be worth a think about in the round, rather than just the individual adult part of it.
Okay, if we can agree that, when do you think you'll be able to do that by? And then Emma doesn't have to harass you about when that paper's going to come.
So it won't be February. I think because we'd want to involve CAMS as well.
Yeah,
I think.
yeah.
So I think realistically, let's say April. Yeah.
April. Cool. Thank you very much. We'll
Sorry,
April.
Could you not do it? I'm not here in April. I'm having a second honeymoon after 40 years. Is it possible to do it in May? Because I'd very much like to be here for that item.
Yeah, I think doing it well is what's important rather than quick, so we'll do it then. So, I can't get my mic to work now. Julie, if we can do this really quickly, because we've got to make sure we're at 11:15 dealing with rheumatology. Thanks.
Julie Garbutt, Non-Executive Director. I just wanted to very briefly put the alternative plea, I suppose, and I declare an interest here because I have a member of my family who's an adult who's going through an assessment process currently. What I was saying is I declare an interest in a member of my family who's going through a diagnostic process currently. And it was just a plea to say I absolutely endorse Claire's request that we should do a thorough review of this across the piece. But it's a request that we do involve those organisations on the island who are getting more involved in neurodiversity to make sure that we get a rounded view, which is not to say that I don't agree with you, but I just think we need to make certain that this is a very high profile issue on the island, as it is, I think, everywhere. It has become something which is talked about a lot. It's very prominent in employment at the moment in terms of employers' responsibilities for people in the workplace with neurodiversity. So I just think it's important that we take the broadest perspective and that we bring other people into that debate.
That's a really good point. Thanks, Julie. So I'm sure you will do that. And yeah, brilliant. Thanks for that, everybody. So our next item on the agenda is the workforce reports, which actually I think Chris highlighted nearly everything that needed highlighting in his report.
Sorry.
So Steve, there's your challenge. Is there anything that he didn't highlight that you particularly want to mention? Because otherwise, I don't think we need to discuss everything a second time.
No, I appreciate that, Chair.
Yeah.
Steve Graham, Associate Director of People. I think you're right, Chris did highlight all of the things I would probably pull out, except to just assure the board that even though we had a successful 2023, we continue to look for new partners to support us in bringing in new staff as well. We're still looking at different websites and different agencies, so it's an ongoing piece. And with Bill in post in the role within HCS, he will be able to pull all that together into a single place rather than the disparate activity that there is ongoing at the minute.
Well, that's positive, and there'll be you can't point fingers in another place anymore, can we? So we'll really have to deliver on what we're saying now, that we've got total responsibility for that. I think the only issue that I would raise, and I think again we need to talk about the issue of appraisals when we get onto the rheumatology report as well, but it's not just for doctors, it's for everybody. It's a low figure. You say it's low, you don't say how low, so it'd be useful just to know how low we are in terms of appraisals completed.
So we are the lowest department in terms of percentages of appraisals completed.
There's the challenge to the executive team then, isn't it? That isn't acceptable, and it's creating issues definitely in terms of you know, people understanding what their responsibilities are and delivering against those responsibilities.
I think, Chair, that we have to be cautious, of that number, because we know that there is an issue culturally about our teams putting this on the new Connect system. And I've obviously do it with the execs, but there is a time that it takes. So if you take nursing, and Kathy behind me, you know, I've been assured with Jessie and Jessie Marshall and Kathy that the nurses do this. You know, the ward managers sit down, appraise all their staff. The real chance, so they've got that written down. It's moving from the written appraisal to then getting all this information on the Connect system. So I'm assured that our nurses are being appraised as they should, unless Kathy tells me I'm wrong, but we just don't get them onto the system. So we have been trying to work with the central HR team and the Connect team to do more training for our supervisors and managers that need to move from a paper-based system of appraisal to getting it on the new Connect system. And that's where, so I say our 1,000 nurses do have appraisals. We just need to get them. But you know, the issues are about a ward manager sitting down, finding a considerable amount of time to then enter all this on the new system. So that seems to have been our challenge, and certainly working, and now obviously with Steve being over in the central government department, he's continuing to work with us on getting our staff trained and focused on getting this into the Connect system. But appraisals do happen.
Yeah, I get that. I mean, I must admit I was number one culprit in terms of not loading things up on the system, so I completely get that. So, so I just think it's good that they say that it is happening. We just need some evidence that it is happening. Personally, I'm less bothered about the bureaucracy around it, more about the understanding of what somebody's objectives are. So I think thank you for that reassurance on that. So Steve, again, a big thank you from all of us. Kathy, is it something new that we really need that's over and above what's been said or not?
No, Kathy Stone, Chief Nurse Changing. No, it's just to reinforce your comment, Carolyn, about nursing appraisals. And I know Jessie is currently reviewing the assessment process, and it may be something we can provide to future boards, whilst it will only be it won't be electronically proven. We will have it at a ward level, so it may give some form of assurance on a quarterly basis.
Well, that would be really helpful. Thanks so much for that, Kathy. So on that, thank you again for all your support and help, and your turn next time, Bill. So the next report was meant to be the annual plan. That's deferred, obviously, because of the PERDA period, and we'll do that at our next meeting. So the next report is on the quality and performance report. Now, when I read this, I thought this is going to be a very difficult report for you to introduce, actually. So there's a challenge, but I know that colleagues will have comments to make on this. And I'm just warning everybody, we do need to finish this item within maximum 10 minutes, absolute maximum. So just warning everybody on that one.
Thank you, Chair. Anushka Mullah, Director of Improvement and Innovation. So yes, maybe just setting a bit the context here. It's the QPR which we just went through and had some questions also around the indicators. We've usually do an annual review to keep them up to date, to adjust them, to make sure they still refer to HCS strategic and operational priorities. So with the change team coming in last year, it was a good opportunity to go through what works well, what could be improved, what should we focus on, but also feedback from this board on the current QPR, quite long. Some of the indicators may be missing, we should have in there, some maybe not. So this report basically provides two aspects. One is the proposed new set of indicators, which have been developed with consultation and a lot of input, particularly from Professor Simon Mackenzie, Kathy Stone, of course the executive team, but also the wider senior leadership team. Also through discussions from the board, so that feedback has been taken on as well. So that's one aspect, is the list of indicators and what standards, if they are appropriate, to take in. The second part is looking at the format. So currently it's a table with each month. and it doesn't really tell the story. And it, because particularly around the Jersey small number issue, if it goes, if an indicator goes up by 2 or 3, that can impact quite heavily. So using statistical process control charts, SPCs, will help getting away from this, instant, oh, it has gone up or gone down. It gives a longer period of time. It shows the trend, but it also shows if the trend is going in one direction over a period of months. So that will definitely help. So I think this sets us in just one item. So we've listed the indicators there. There's also a reference to what goes to the Government of Jersey website, which are called service performance metrics. And the maternity metrics, they will be quite long, and there will be a specific dashboard be developed, which there's a bit of a mock-up here. And then just to reinforce the December report with the statistical with the SPC charts, this is a work in progress. So this is really for comments around design that has been developed and is aimed to be in place by next month for reporting on month 1.
So I think in terms of design, I think we can give you individual feedback.
Yeah, absolutely.
Yeah. But I think there's some more fundamental issues that I know both Julie and Tony wanted to raise. So over to yourselves.
Thank you. I absolutely agree with looking at lists of data and not just providing data for the sake of data. I think the thing that concerned me, I may have just misunderstood it, hopefully, but it's the loss of so many data items around demand, activity and waiting lists. There's no doubt that to the public of Jersey and to the politicians of Jersey, they're very interested in this. They do see it as a marker of how well we are performing. And I'm very mindful of the comment you made earlier, Chris, about the need for us to be laser-like in our perspective around waiting lists. I'm not sure we can do that as a board if we lose this level of information. Now, maybe it can be dealt with at assurance group, and then we have more of the exceptions coming through to the board, and I would support that. But to not have sight of this and to not have this in the public domain, I think is an error. And I think it would come back to us. I'm very mindful also of what Claire said earlier. The data that we've seen so far does show that year on year we've seen increase in demand, we've seen what looks like reduction in delivery, and we've seen waiting lists grow. Now, I'm very confident that the things that you've told us that are happening, that will start to come through in the data January, February, March this year. But at the moment, we won't see that on this report, unless I've just completely misunderstood, and I'd be delighted to be told I have.
Just Tony, is there anything you particularly wanted to come in, and then people can sweep it all up a bit quicker?
Yes, that's probably the best approach, thank you, yeah. First, it's good to see this, and I know a lot of work's gone into this really, and it really is worth the effort to get this right, because I think as the board, of course, we've been talking about the difference that we want with the services as a whole, to be making over the next 18 months or so. And the indicators and what we're seeing needs to kind of reflect that. So we've got a real sense of progress here at the board, and the public has, of course, as well, given the commitment to openness and transparency. I think as well there's something you said earlier, Chris, about diversity and inclusion and so on. So the indicators really need to reflect much more than numbers, if I can put it like that, really. It's how we measure these much more difficult quantitative measures one way or another. And Andy, you and I were talking last night about how the out-of-hospital stuff needs to really reflect what we're trying to do for quality of life for people in Jersey. And Andy, you were talking last night about how we tackle homelessness, how we tackle inequality of access to services, and a range of other things as well. So there's a lot to talk about here that we can't just deal with quickly here. So I think what we need, Chair, really some form of process actually over the next month or two to really get this right. And of course in line with new ministerial priorities and commitments as well, given where we ultimately report. But the openness and transparency of the journey that we're on now in making things better together is absolutely critical, and that's way beyond just some indicators.
So I know Claire wants to come in and discuss yourself, but I think basically what's being said is we just need to do a little bit more work outside this committee or this board, you know, to get this in a way that everybody feels comfortable with. And I agree with Julie that when we have the assurance subcommittees up and running, maybe more of the detail into those, and then, you know, something of this nature to the board. So as long as it's all being addressed somewhere with some external challenge, then I think then that is appropriate. But anyway, over to yourself, Claire, and then yourself, Anushka, and then we'll move on if that's okay. Sorry, I turned it off.
Okay. Thank you, Kat. I just wanted to reassure Julie and also the public in terms of the discussion around waiting lists. So obviously what we're doing is that we're becoming more transparent about people waiting long times. The current QPR talks about people that have been waiting for 90 days. What we're going to say is we're going to show to the public the people who have waited over 52 weeks. So we're going to be really focused on the long wait, on the waiters, and, you know, look forward to obviously showing that we don't have any in those cohorts. Obviously the access to diagnostics, again saying that how many people are getting seen within 6 weeks, because we know how crucial that is to pathways, and also particularly with the work that we're doing in relation to cancer access, being able to show that we are getting swift diagnostics so people get a diagnosis, and then obviously demonstrate how we're going to treat. These QPR metrics in no way obviously detract from the separate waiting list paper that we can bring to board as often as is required, that it sits monthly in terms of our own internal governance, and also again to reassure the public that we have been doing the piece of work in relation to what used to be available on the website. That is sort of in the final stages of development, and I expect so I can hopefully share at the next board the actual date for it being live, if not available already by that point. So I just wanted to reinforce those points.
I think that's really good reassurance, actually, and I must admit some of these the way that you're presenting this going forward is more what I'm used to from an NHS perspective. I think the area that I would have a slight concern about is we don't forget about social care, because you would see a lot more data as a local authority, chief executive or councillor in the UK than is proposed here. So we just need to make sure it's not just all acute services, but it's community services that's getting enough scrutiny as well, really. But Danushka, you can have the last word.
Thank you. Just a little bit of reassurance. So waiting lists, absolutely committed to that. As Claire said, there are some specific indicators there, but also we are working on having waiting lists again on the website, where people can actually access that by service and in a better way, rather than saying the number of people waiting. It's more, which was kind of, you know, from the past history, it's what is my waiting time at the moment. So we're working on that, so that will go live. Of course, that would be far too detailed to bring that into this report. There was a balance of, we had the conversation here to be concise, so what are the right metrics, and based on that, for transparency reasons, we included the metrics that basically would come out from the current one, but it doesn't mean they have been all deleted. Some of them have been replaced with the metrics which feel more like the standards we could benchmark with. So that was a lot of advice, particularly from Simon McKenzie as well. And then I'm happy to look at Tony to work on, you know, your comments to do that. We may want to do something thinking about Statistical Jersey, produce a lot of island-wide information surveys and stats, which we may want to bring in themes over time to the board, looking at operational data, but also more island-wide ones. So we can have a look at how we can cook.
Excellent, good. Well, thank you for that, and I think this is the right thing to do. So we just need to, as just said, make sure we get it right. And you did say it's an iterative process, so we can change it as we go. I think one of the just little detailed things on the trends. Some trends will ordinarily be a flip-flop issue. You know, so it's normal that some stats go up and down, and it's a flip-flop. Some of it's going down, it's really serious, and others of it's going up, it's really, really positive. And I think it would be helpful for us just to have some way that you could put by it on the trend to tick a question mark because it's a flip-flop, or a cross because it's really not good, or something of that nature. So it's just an indicator. These are the ones we're really concerned about, and this, you know, does go up and down, and it's
and the
small
SBC
numbers.
charts help very much.
Yes.
That's what, again, I'm used to seeing because it's more informative.
Likewise, yeah.
Thank you for that. Thanks very much indeed. So we'll move on now to what is a very brief report on serious incidents. I think we'll need more on this going forward, to be absolutely honest, Patrick. But again, once the Quality Assurance Committee is up and running, this is very much their area with escalation to the board. So this is just giving us an outline from what I can see of the process of serious incident review. So over to you, Dr. Armstrong.
Thank you, Chair. I'll take the report as read, and Chris obviously alluded to the position in his overview earlier on, so I'll not repeat that. I think areas that I would highlight to the board, particularly around massive obstetric hemorrhage, which we recognise as being an issue earlier in the year, so any MOH that's referred to that occurs in the organisation comes to the Serious Incident Review Panel as a matter of course, and there's an immediate huddle afterwards to see if there's any immediate learning. Obviously we've brought a lot of those cases together for the review by niche, and hopefully we will get the learning from that, I hope in the next few months, but we're dependent on them producing the report for that. But what I would say around it is what we have seen in terms of the management of major obstetric hemorrhage is that compliance to the sort of care bundle that's in place for it has improved very dramatically, and there were no incidents during November and December where it wasn't followed, which was not the case early in the year. And just to understand that, it's a response when you're seeing the MOH has occurred. There's a sort of pathway that you need to follow, and compliance to that is much better. I think what we hope we will learn from the niche report is that we're seeing the management of this occurring. MOH is I'm not an obstetrician, but my understanding is a fact it will occur, so how you manage it is important, but also what you can do to prevent it happening in the first place. And I think that's what we'll hope to learn from the niche report when it comes out, to see if we could reduce the numbers, but I think it'll never get to zero, because there are people who are at significant risks for a variety of reasons. In terms of the themes that we're seeing, I think we've reported previously on them, that haven't changed, but in terms of nutrition and hydration, failure to escalate on occasions, deteriorating patients, and the administration of psychotropic medication have been themes coming through. But there's work in all these areas. We've heard about the MUST tool. Andy Weir is part of the group leading on the use of psychotropic medication, and training in that area has been implemented. And the Recognise, Escalate and Rescue programme that's been running for well over a year now, we've seen significant reduction in the number of SIs coming through where there's failure to escalate. So we are seeing progress. We absolutely recognise there's a lot more to do in this area, but in terms of number of SIs open, time for reports to be done, and for the reports to come back to the Serious Incident Review Panel, it's not where it should be, but it is coming down.
Absolutely. Thank you. Any comments or contributions from people? Claire?
Just a comment. I mean, thank you. I mean, it is coming down. I still think there's too many, but you're working very, very hard to bring them down, so thank you.
Yeah. I think my only comment was, and I agree, it is good that you're progressing this, and this is, without really pushing on this, then we can't be serious about good and assured clinical governance in the hospital. So, I think it is really, really excellent that you're pushing this, Patrick, and Chris as Chief Exec as well. But I did wonder how you can go from having 20 separate SIs, which then become one.
Yes, I mean, for transparency's sake, those are all individual SIs, but rather than try and, given the challenge to investigate an SI on its own, you will see themes. So what we're trying to see is the themes coming through, and clumping them together makes it a much more efficient way of getting to the point of what can we learn from it.
That's fine, and that makes sense, as long as those separate SIs are separate SIs for the individuals involved. That's absolutely fine, thank you. Apparently, is it Kathy who's indicating? Thanks.
Thank you, Carolyn. I was going to come in on the point about the aggregated SIs. It is quite common if you work with niche on the mainland, and Andy will have seen this in mental health when we have a theme of trends. Niche are very receptive to looking at almost a bundle of SIs and to assure the board that there is a very clear audit trail and link to every one of the SIs on the system to actually identify that we will not be looking them at a blanket, but it's that level of pulling it together. And also, Caroline, just to add there, what has been, Patrick and Jessie have implemented over the last 12 weeks are our clinical governance reviews, which allows more granular look at each SI, the recommendations, have they been implemented, where is the evidence and the trends. So really, the organisation is now tackling this challenge in two directions. One, as you said, that the digital, the granular basis, but also putting the patient first. What is the difference and what are we changing in the here and now?
That's really good to hear. Thank you very much indeed, Kathy. So I think on that basis, really good that you're doing this. Obviously, it will be overseen by the Quality Assurance Committee going forward, which Claire is going to be chairing. So, but it doesn't mean that we won't have any issues that need escalating must come here from serious incident review. So, and actually, I think I would personally say if there is what I would call a never event, then that must come to the board ever. And for clarity's sake, never is events is something that should never ever happen, and it should come to the board. Yeah. So yeah, thank you. Brilliant. So on that basis, as promised, at 11:05, wow, we're going to have a break for 10 minutes. If everybody could be, if people are ready before 15:15, I can start and give us longer time that we've got. We must finish at 12:30, whatever. So 11:15, we will definitely start on the dot on the rheumatology item. Thank you. Now, deal with the rheumatology report, which is obviously a highly sensitive issue. Just to highlight our role as a board in relation to this. So we are here as a board, and particularly as non-executives, to be absolutely clear that we understand the governance issues which were not in place, which need now to be in place, and which would give confidence to ourselves and, more importantly, to the people of the island that something of this nature could not happen again. So I see that very much as our role in going through what has happened and looking to the future about what, I mean, I imagine a lot has already happened since this was originally raised, but looking to the future to make sure that people have confidence that they are coming to see a rheumatology service which actually is appropriately qualified and is providing an excellent service to the people of the island. So I think that is our role. There are separate issues related to employment issues, and those are things that we cannot discuss, specific employment issues in a public meeting. They are entirely confidential between the employee and the employer, and we need to remember that the employer is actually the government of Jersey rather than independently as health and community services. So we just need to bear that in mind, and I'll be quite sharp with chairing if we go into any areas which I feel kind of are really inappropriate in any way, and anybody else should as well, because we have a duty of care to an employee. So if I can open on that basis, I'm going to pass over. The way we're going to deal with this is going to be Dr. Patrick Armstrong, who's our clinical medical director, is going to start, followed by Dr. Adrian Noon, who is the, I've got the title somewhere, Adrian, I think it is the Chief of Service for Medicine, is going to then contribute, and then we'll pass over to Chris as the relevant Chief Officer for the service. So that's the way we're going to deal with it. Members of the public are very happy at the appropriate point to ask questions as well. If anybody wants to ask a question just you could indicate to me by putting your hand up, then I'll do that. But bear in mind what I've said about employment issues and indeed the service issues. I'd be really grateful. So on that basis, I'm going to hand over to yourself, Dr. Armstrong.
Thank you, Chair. As you're aware, earlier this week we published an independent review of the HCS Rheumatology Service. As the Medical Director of HCS, I commissioned this review from the Royal College of Physicians in England, or the RCP as we will refer to them. The review was based on a number of interviews conducted by the RCP review team and their in-depth review of case records of 18 HCS rheumatology patients. The RCP team's overall conclusion was highly critical. They said, "We found the standard of care to be well below what the review team would consider acceptable for a contemporary rheumatological service." The RCP had criticisms of both HCS itself and of individual doctors. With respect to patients' notes prepared by clinicians working in the rheumatology service, the RCP said, "There was little evidence to support a relevant patient history having been taken. There was a lack of relevant imaging to support diagnoses. There was limited and often absent handwritten evidence of the clinical interaction with patients. Letters were brief and generally uninformative. In some cases, there was no evidence of clinical examination. There was an absence of reference to a specific diagnosis and on occasions an incorrect diagnosis. And despite a lack of clear diagnosis, biologic agents were prescribed with frequent and multiple changes." The review also concluded that patients were initiated on biological drugs which were frequently switched without giving enough time to determine their efficacy, and noted that in some cases patients were treated with 5 or more biologics within a short period of time. The RCP also noted that in many cases the prescribing of these powerful drugs was out with both UK and European guidance. The review team also observed that many of the staff working in the rheumatology service at that time, including both medical and non-medical staff, were not formally trained in rheumatology. Neither Dr. Y nor Dr. Z, the 2 doctors identified in the review, were on the GMC Specialist Register for Rheumatology. This whole affair, this concern about the rheumatology service, emerged in January 2022 when a junior doctor raised some concerns about a more senior consultant physician who was referred to in the review as Dr. Y. As these concerns were wide-ranging, HCS restricted Dr. Y from undertaking any clinical practice and began an investigation. During this initial investigatory period, it became apparent there was little regard for national or international guidance, and there were anomalies in the prescription of drugs used in treating rheumatological conditions. These anomalies and further concerns were subsequently raised by another locum consultant. The further concerns included questions of record keeping and the clinical assessment of rheumatology patients. Partway through their review, the RCP review team were concerned enough about clinical practice in the rheumatology service that they wrote to HCS indicating that neither Dr. Y nor Dr. Z should work independently in providing rheumatological care until the RCP review was completed. The letter also recommended an audit of patients on biological drugs to ensure their diagnosis was secure, or in other words, correct. Now for the public, this might be an appropriate moment to indicate that biologic drugs, or biologics as they're sometimes called, are a group of powerful drugs derived from natural sources such as human, animal, fungal or microbial cells. These drugs work by suppressing the immune system, disrupting the inflammation process that leads to joint pain and damage. They can be and are very valuable drugs for rheumatology patients, but they should always be used with caution, as they can also make patients more susceptible to life-threatening infections and can have significant other side effects. In line with RCP recommendations, HCS has now completed the audit of every patient on biologic drugs and has gone further by reviewing the case notes of other patients seen by Dr. Y and Dr. Z over the 3-year period prior to January 2022. In a minute, I'm going to hand over to my colleague Dr. Adrian Noon, to explain what we have discovered while completing these audits and reviews. But let me first address the question of what this means for Dr. Y and Dr. Z. It is widely known in Jersey who Dr. Y and Dr. Z are. Dr. Z no longer works in Jersey, but Dr. Y remains an employee of HCS, and we owe him an important duty of care while he continues to be our employee, including a duty of confidentiality. We are therefore adopting the terminology used in the RCP report and referring to him simply as Dr. Y. However, it is also important that patients know whether it is safe to receive care and treatment from any given doctor anywhere in the UK, and in order to have that assurance they must be able to identify a particular doctor and check his or her registration on the General Medical Council register. It is therefore appropriate for us to confirm that the General Medical Council, the GMC, has placed restrictions on what Dr. Y can and cannot legally do, and in this context they have publicly named him. A link to these interim restrictions on Dr. Y can be found on the Government of Jersey website. The restrictions include restrictions on his ability to prescribe drugs, a requirement to attain the approval of the GMC before starting work in any non-NHS setting, a requirement that he does not undertake any rheumatological work, and a requirement that he be supervised in any post by a clinical supervisor. In terms of Dr. Y's professional registration, we have sent the RCP report to the General Medical Council, and it will be for them to decide whether it has any impact on his ability to practice as a doctor. With respect to his current employment with HCS, we will be carefully considering this report and discussing it and its implications with him. Dr. Y is currently restricted to non-clinical work and is not therefore performing clinical duties. Dr. Z no longer works in Jersey, but we have sent the RCP report to his present employers, and it will be for them to consider the implications for him. With that, I'll hand over to Adrian.
Thank you, Patrick. Can you hear me okay?
Mm-hmm.
Yeah. Let me begin by summarising the results of the audit of biologic patients that we undertook. As Patrick explained, this audit was an interim requirement of the Royal College of Physicians review. In total, 341 Jersey patients were on biologics at the time of the audit. All of these patients have now had their notes reviewed by locum consultants on the GMC Specialist Register for Rheumatology. Those who are still living in Jersey have now been seen by a specialist rheumatologist, and they are all now receiving appropriate care from our new rheumatology service, which is led by Dr. Sophia Tosanidou, a consultant on the GMC Specialist Register for Rheumatology. The clinical audit methodology we adopted was based on the British Society for Rheumatology audits. It was reviewed by 3 senior rheumatologists and was approved by the Royal College of Physicians. In over half of the records reviewed, clinicians were not able to identify sufficient evidence to support the patient's diagnosis, and approximately 1 in 4 of the patients reviewed had their biologic drugs discontinued because they were not felt to be necessary. This audit of rheumatology patients on biologic medication raised such significant concerns about clinical practice and the consequential potential harm to patients that HCS decided to undertake further clinical reviews covering every other rheumatology patient, as well as those non-rheumatology patients who had been under the care of Doctors Y and Z referred to in the RCP review. These further clinical audits were also conducted by locum consultants on the relevant specialist register. The first of these additional reviews covered over 1,000 patients who had been prescribed disease-modifying anti-rheumatic drugs, or DMARDs. The clinical audit of case notes for this group has been completed in over 95% of them, and 95% of these patients have now been reviewed in clinic. The few remaining patients are scheduled for a review appointment in January of this year. The review of this group of patients has resulted in the diagnosis of over 45% of these patients being changed, and 1/3 of these patients have had their DMARDs stopped. The second additional review covered the case notes of 386 rheumatology outpatients who were under the care of Dr. Y or Dr. Z. This review indicated that approximately 50 patients should have had their care reviewed at a clinic appointment, and all of these patients have now been contacted to schedule such an appointment. The third additional review involved 747 non-rheumatological inpatients who had been under the care of Dr. Y or Dr. Z. This review is approximately 80% complete, and the main finding is that very few of the patients, less than 3%, have had their treatment changed as a result of the review. The final additional review has yet to be started. This will be a review of any patient seen by Dr. Y or Z in the rheumatology clinic in the period since January 2019 and who has subsequently died for any reason at all. To be clear, this will include many patients whose cause of death had nothing whatsoever to do with their rheumatology care. This review will involve a clinical audit to be followed by a mortality learning review or MLR for any case where concerns are raised. Before handing over to Chris Baum, the HCS Chief Officer, I should say that the wide-ranging review of patient care I've just described is a truly comprehensive review programme. We have gone way beyond the more limited review recommended by the RCP because we wanted to leave no stone unturned in our efforts to ensure that patients in Jersey are now receiving the very best possible care. In total, we have reviewed around 2,400 patients, and we have recalled for clinic appointments any of them who needed a face-to-face clinical review. The RCP review is highly critical of the practice of two doctors, Drs. Y and Dr. Z. It is worth remembering the duties of a doctor, which are detailed on the GMC website. They include the following. You should provide a good standard of practice and care. You should keep your professional knowledge and skills up to date. You should recognise and work within the limits of your competence. You are personally accountable for your professional practice. You must be competent in all aspects of your work. You must be familiar with guidelines and developments that will affect your work. The GMC also says that if you assess, diagnose or treat a patient, you must adequately assess the patient's conditions, taking account of their history and symptoms, and where necessary, examine the patient. You must prescribe drugs only when you are satisfied the drugs or treatment serve the patient's needs, and you must ensure that your clinical records are clear and accurate. The RCP review touches upon all of these issues which are pertinent to the practice of the doctors concerned. Having said that, I think it is important to understand that the RCP review is not just a review of the practice of two doctors, it is also a review of the wider HCS rheumatology service. And to explain this further, I shall now hand over to Chris Baum.
Thank you, Adrian. Yes, the RCP review clearly wasn't simply just a review of the practice of Drs. Y and Z, it was a wider assessment of the whole HCS rheumatology service, and in this context the review again makes a number of critical comments and offers a series of recommendations. It says the review team found no evidence of agreed pathways, standard operating procedures for most aspects of routine rheumatological care. It notes that both public and private patients were being seen in the same clinic, and there was no meaningful explanation of how this overlap of private and public patients was managed or planned. It found no evidence of the provision of a formal multidisciplinary team meetings. It was concerned to hear that there was no oversight of the prescriptions being dispensed to rheumatology patients. And it notes that there was a lack of built-in challenge to prescribing, particularly biologics, by the pharmacy team. The review makes a number of recommendations, including the need to establish standard operating procedures, the need to standardise written correspondence templates to reduce the risk of missing key information within communications, the development of close links with another NHS rheumatology service to enable forums for sharing best practice, and a recommendation that the pharmacy team should review the arrangements they have in place for the prescribing of biologics. A recurring theme through the RCP report is the lack of effective governance, not just in rheumatology, but across HCS. In this context, the RCP report, of course, is consistent with the findings of the review of governance and quality of care in Jersey that was completed in the summer of 2022 by Professor Hugo Maskey-Taylor. That review made over 60 recommendations, and I can report that we are making progress on actioning these. I think it would be helpful just to give a few examples. As Dr. Noon said, we have now appointed a new specialist rheumatologist to lead the Jersey Rheumatology Service. We have stronger governance frameworks, and we've mentioned earlier the monthly care group governance meetings that have been in place over the last few months. In addition, of course, Jersey has established its independent advisory board, and we have made it clear to clinicians in HCS that they must now follow appropriate clinical guidelines such as the National Institute of Health and Care Excellence or other equivalent evidence-based clinical guidelines. We are assuring that clinical specialties now take part in UK national audits to support benchmarking, so we and the people of Jersey can make judgments about the quality of service that we are providing. We have focused initially on services where we have particular challenges, such as maternity, which we've mentioned earlier, and where we've been reporting the progress that we're making against the maternity improvement plan to this board in the past. And you've heard about us and our efforts to improve serious incident reporting, and importantly ensuring that lessons are being learnt. In its report, the RCP review team notes this progress. They say it was reassuring to hear from senior managers that steps were being taken to implement a governance framework. And the team went on to commend HCS, and in particular its medical director, Mr. Patrick Armstrong, for ensuring the concerns that were raised were appropriately investigated and taking forward the work of improving governance. This action was done to ensure patient safety. Now, one of the most important aspects of clinical governance is the commitment to openness and transparency. And in the spirit of openness and transparency, it's important for me to say that from the work that we have done, which Adrian has just described around the audits, it is clear that a number of patients have had their diagnoses changed and or their medication changed. And it is inevitable that some of these patients will have been harmed, clinically and or economically, by their earlier diagnosis or treatment. We expect and hope that in most cases the level of harm will be minor or negligible, but of course any level of harm is completely unacceptable. And over the coming weeks we will be contacting any patient where we think harm may have been caused, and will be discussing with lawyers an appropriate approach to compensation. Earlier this week we were in contact with the Jersey Arthritis Association, and I think that the current position was well summarised by Maureen Paris, the association chair. She said, "We welcome the publication of the RCP report and we applaud the decision to commission this in the first place. The task now is for everyone to learn lessons. It's essential that the General Medical Council is made aware of any clinical practice that may impact on the right of a doctor to continue to practice medicine. And it's equally essential that HCS institutes a more robust and effective framework of clinical governance as rapidly as possible." So in conclusion, I'd like to say this. It's very important that our healthcare staff feel free to speak up, and when seeing something particularly that is not right. And when a junior doctor raises concerns about the practice of another doctor, even perhaps a senior and well-respected doctor, it is vitally important that these concerns are taken seriously, fully considered and thoroughly investigated. That is what we have tried to do in this case. What has emerged is a picture of a rheumatology service that none of us can be proud of. The people of Jersey deserve better, and we are deeply sorry that we did not provide the service that staff, patients and our community could be satisfied with. Our task now is to make the improvements recommended by the RCP and to ensure that HCS becomes a beacon of good governance, not just in rheumatology, but across the full spectrum of health and care services. Nobody doubts the fact that our staff are hard-working and well-meaning, but that is not enough. Modern healthcare organisations must also have good governance, and as this RCP report indicates, the cost of not having good governance is far greater than the cost of getting it right in the first place. Thank you, Chair.
Thank you very much for that, all three of you, and I think we should commend the junior doctor who basically raised the initial concerns about this issue. I think it's a brave thing to do, and I think we should thank them for doing so. And I think we should also say, Patrick, that you did the right thing in commissioning reviews, and Adrian, your role in that as well has been really very well received as well. So I think in that respect, I think, the department has done the right things. However, the department didn't do the right things before that, just as the individual doctors didn't do the right thing before that, and that's what we need to make sure that those issues around clinical governance. And I think perhaps I could say the culture of good clinical governance, because I'm not sure there is. And I think the first question I'd like to ask, I know that I've got lots of questions, I know other colleagues will as well, but the first question I would like to ask of you, and I don't mind who answers the question, but are you with Hugo's report as well, this would raise concerns to me about the culture of good clinical governance in our services here, and whether there is a culture of good and appropriate clinical governance in our services. So that's my first question, because if I was a patient on Jersey, I would be very concerned.
I think in the past there hasn't been a culture of good clinical governance in Jersey. That's one of the reasons why I'm, along with my former colleague Rose Naylor, Chief Nurse, asked for Hugo Massey-Taylor's report to be commissioned in the first place, because we were very concerned about clinical governance. I think for patients walking through our doors today, hopefully what's we've described and what's described in the paper, of all the things that we have done in this service does not look anything like the service it was in January 2022, and I would commend all the staff working in that service, and I'm sure Adrian might have more to say about that, for the efforts and their determination to make the service much better. And I think patients should be reassured, because there are all sorts of things, but I'll leave that for you to describe. I think we have to remember that there's over 200,000 people walk through our doors into our clinics every year, and the vast majority of those people get really good care. Part of what we've described today is that, and as Hugo said, we can't evidence that, and that's the journey that we're on, and we are seeing more evidence that care is improving. I think I would say that this is not usual. I think some of the practice that we've seen in rheumatology is well beyond the norm, and the vast majority of our colleagues, both medical, nursing and AHPs and across the hospital, do engage in good clinical governance and do want to provide the best care that they possibly can, and the vast majority of our colleagues do follow guidelines and believe in NICE guidance or European guidance or American guidance, but we still have an awful lot to do in that area. So I think this is a journey that we're on. This board is part of that journey, and all the things that we've been discussing today, I hope would give people some reassurance that we are addressing these issues.
Thank you for that, Patrick. Claire, you have indicated that you'd like to ask questions.
Just a few things. First up, just a comment. I mean, this is Jersey Healthcare's sort of mid-staff's Bristol Heart event, and I know it's very, very painful, because I've been a doctor for that, I've been a doctor for other major inquiries around in the NHS, and it's very painful coming to terms with the fact that collectively one has failed the patients that we serve. I don't believe it's just the rheumatological department. I've read the report. If you look at the report, it highlights pharmacy, for example. Now, these will have cost the island of Jersey, the taxpayers, millions and millions and millions of pounds. These are not cheap drugs. They were about £1,000 a dose. I don't know what they are, what you buy them for, but they're incredibly expensive. So not only has there been harm to individual patients, but there has been harm to your economy in all of this. That's the first thing. So, but pharmacy has been indicated within the report, and quite heavily implicated actually, that they should have been alerted to these. They say they didn't have access to clinical records. I don't believe that. If you had paper records at the time, you ask for paper records. So that's the first thing. Also within the report, it mentions that in 2016, it was recommended by the RCP that there was a review of consultants' adherence to NICE guidelines. And that was parked because the consultants didn't want it. So this isn't just the rheumatological, this is within the system that it works. There's also within the report the mix of private and public. And as I understand it, and you'll have to, that some patients were seen privately, but issued with the equivalent of the health service, I call it the National Health Service, forgive me, but you know what I mean, prescription. In other words, they were being seen privately and then getting their prescriptions publicly through public funds, even though some of them probably had private insurance. So to my mind, that's fraud. Unless you tell me otherwise, maybe it isn't fraud, it would be fraud in the NHS. And then I understand, so it's not, I don't want you to comment now because these are things that are going to have to come out, but then I understand that this doctor, and I don't know who he is at all, so I have no vested interest in this, you've just said is not doing clinical work, but he's still on your payroll. The only assurance I want from you is that there's rapidly going to be a process that this doctor is taken to task. He's caused a great deal of damage, whether or not he's a good doctor. There has to be a process. And finally, I am concerned, or can I be reassured that this isn't happening in other departments? And I have asked, and I will have a look at your prescribing data, not to go, I'm not going to go and say, why is this doctor prescribing this, but to look at what is going on, because this should have been noticed. Anybody with oversight of prescribing data should have said, what on earth is going on that you're spending, I don't know, £1 million a year on biologics for a tiny population? Are you doing the same for opiates? Are people being prescribed fentanyl? Are people being prescribed oxycodone? Are people being prescribed medicines of no value whatsoever at vast cost because the public are asking for them, but not because they do any good? So these are the sort of things that will come out, and I think in a way it's good that this has happened. I know that sounds awful, it's not good for the patients, but this is your Morecambe Bay moment. I'm sorry, it just is, because the onion will now be unpeeled to see, and this will be the moment that things get better, as you said, Patrick, they're already getting better, but I don't think this is just going to be put to bed and that's the end of it.
So Patrick, before you come back on that, or Chris or whoever, I'd also like to raise the issue of pharmacology, and I like Claire, I think there is an issue here that should have been spotted. So I would like to ask, because you said that there is going to be an audit of the prescribing of biologics. I think you should be auditing more than that. And I think you should be looking at the connection between pharmaceutical companies, pharmacists, and doctors across the piece. So, and I think that should be done as well. And including in that audit, you need to do, as Claire has said, the issue between public and private and how that mixes between the two issues, because the report is very clear that that is not transparent. So I just wanted to support Claire in that and say that audit that you're going to do, I think, needs to be a little broader. But anyway, if you'd like to come back on all of that.
Yeah, so in terms of things that have been done, one of them is the appointment of a biologics pharmacist, and I think they're due to start next month. It's been appointed who will specifically look at these drugs. I think as a broader piece of work which we have started is looking at the role, and just to emphasise there have been changes in the leadership within pharmacies since this time, but the role of our chief pharmacist is quite unique in Jersey, in that they work, a lot of their work is outside of HCS. They're involved in the inspection and regulation of pharmacies on the island. A lot of their time's challenged taking up within the growing cannabis industry, and the prescription of cannabis on the island takes up a lot of their time. So we've been looking at that role and how that role is supported, and I think there does need to be more support going in, and there has been a paper come to SLT which we're still discussing. The senior leadership team proposal as to what the structure within pharmacies should look like, but there's some more work needs to be done around that. In terms of the private and public issues that you've raised, absolutely, I think we would welcome an audit of how that works. I think there's probably a lack of clarity because obviously these patients, maybe if they were a public patient they would be free, but there needs to be absolute clarity on how that works. I think in this instance it's unusual in that public and private patients were being mixed in the same clinics. That's not how...
the report said they were mixed.
I'm saying that they were.
As did Hugo.
I don't think it's typical.
It's not typical more broadly, and you know, we need to understand. Well, it doesn't happen.
Is the prescription pad being taken to the private clinic? You don't need to see the person in the same physical space, but if you have your prescription pad in the private sector and you're giving, I call it NHS, forgive me, but you're giving an NHS prescription, in the UK that would be fraud.
Yeah.
I'm assuming that's fraud here.
Yes.
Okay. And sorry about to interrupt, but also, do you have a register of conflict of interest? Because I would be concerned, you just mentioned cannabis industry, that's a phenomenal, I mean, again, I did cannabis, I didn't, but I was on the UK CMO's group for cannabis. That is a phenomenal money generating, and I'm assuming that all of the workers, all of the people for Jersey that are paid through the public fund have a declaration of conflict for themselves and any significant others, families, friends, relatives, so that it's all transparent. Because I think when this is dug down, there's going to be issues around conflicts and people who aren't honest and open about their relationship. And the chair has already mentioned pharmaceutical. I don't know whether we need to know how some of these people involved with pharmaceutical. So do we have conflicts of interest registered?
We do. Well, Emma, you've been obviously working on this as well. Certainly, around the executive, we have conflict of interest. We have to sign a conflict of interest. Obviously, before meetings such as today, we ask people to declare conflict of interest. And I think the issue, Emma, now is about how we then, because it's a relatively new thing in Jersey.
Staff who are in position of not here in this room, but staff who are not in this room.
And that's the next stage, Emma. I don't know if is there anything you want to add about how we're doing that?
Yeah, so, you know, as a starting point, my understanding is declaring any conflicts is a condition of employment. What the government have recently launched is an electronic form to help support that. We've gone over and above that, so there isn't a mandatory requirement at the moment for staff to make a null declaration. So we are following the requirement at the moment for all tier 1 to tier 3 staff to complete the declaration form, and in addition to that, anyone in the organisation who has a role in advising or placing contracts or involved in raising invoices. So we're actually mandating that we require people to make a null declaration as well, so we can be completely assured that we've got out to everybody that we need to. So we started this piece of work at the end of September last year, and going forward monthly we'll be reviewing the register that's held centrally to make sure that the management of any declared conflicts is appropriate.
I think it's worth saying we have clear guidance on the relationship with the pharmaceutical companies in that they should not be directly approaching any clinician within an organisation. They should be coming through procurement and doctors and other staff should not accept direct approaches from the pharmacy.
That's clear in the GMC.
Yeah, I'm sure that these are in all guidelines, etc. But I think what we want is reassurance that those guidelines are being adhered to, because I don't think we've got that at present. And whilst you say, and I completely take what you're saying absolutely as your belief and etc. and genuine, but I think we'd like to see, confirmation evidence that the public-private split is properly being dealt with across the piece, not just in this area. I've got some other questions. I don't know if anybody else has. Tony, have you got some questions before I come in with mine?
Just a quick comment, Chair. Thank you for that. I think you've already said commending the junior doctor who raised this, and this is a very difficult day for all of us, really. It's very painful, and it should be. But let's remember the junior doctor did raise this, and that's what's led to today, with all this up and down and so on, really. So I'm hoping that this is a message which reverberates throughout HCS, that if you've got concerns, and especially, we don't want this to be a substitute for good management. Whistleblowing and so on should never be necessary, really, in a good culture of good management and listening and so on. But nevertheless, this junior doctor did raise this, and it was, and that's what's led to today, and that is a good thing, really. So we should remember that and applaud that and enable this to reverberate around HCS. That if you've got concerns, you raise them. We're committed to openness and transparency from the board downwards.
I think just on that, this is exactly the culture that we, any organisation, health organisation, speaking up is sort of a core essential to addressing problems and particularly poor practice. So I've always encouraged everywhere I've worked in the last 30 odd years that is part of the process of good governance, and certainly as we know that the culture that was raised in the Hugo Massey-Taylor report, but we've spoken to it before, is the thing that we need to change. People need to feel confident to speak up, and I think the courage of the individual junior doctor, it's probably the most difficult thing that anyone can do, is to be commended. And I think we are seeing, because people come to me and indeed to Patrick and others, and freedom to speak up, where they are starting to raise concerns about various things, and that enables us then to thoroughly investigate those issues. So it is a sort of the central spine to assuring that we provide high quality care. So I'd absolutely agree, and there is more to do on that. I think, just going back to Patrick's point about the culture of clinical governance in Jersey has been, behind where it should do, perhaps 20 years behind from my experience where it should be. And we now have to work with our senior clinicians, and as I think Claire, you highlighted in the RCP report, that this wasn't always encouraged, or back in 2016 when this was raised, that clinicians didn't want to follow guidelines, etc., and quite frankly that's not acceptable. These guidelines are evidence-based, whether it's NICE, whether it's European standards, whether it's even American standards. We have to ensure that our clinicians are following those guidelines. We must never let this happen again. And it seems to me that if that had happened at the time and over the last 25 years or so, that if that expectation was made clear, we would not be where we are today as regards to rheumatology, because that would have been picked up that guidelines weren't followed. So it is absolutely essential. I've made clear, Patrick's made clear, I think the board's made clear that that is our expectation. Now, there is work to do with some clinicians about that, to be frank, and that is something that Patrick and the Chiefs of Service, and indeed Claire, and indeed Andy in mental health, all need to be working on, of which they are. So this is something that is, as I say, tragic is probably even not the right way to describe it, but it is, I hope, a watershed moment for clinical colleagues as well as managerial colleagues as well as the whole organisation, indeed including politicians, that something now needs to absolutely change, and the support and momentum I think this broad board will bring to ensuring that these things are addressed, that we are clear about our expectations of good clinical practice and of good governance and safeguards. Pharmacy, as you say, was mentioned a lot here. This has to be, as was the Hugo Massey-Taylor report, with its 60-odd recommendations, something that this board really, it's central to driving that improvement.
Absolutely, thank you for those reassurances. I've got 3 issues that I'd like to raise, if that's okay. Can we just do the easy one first, which is what we are being asked in the report as a board is to nominate one non-executive director to oversee the process going forward. Claire Garrard, who is a doctor and who is going to be chairing our quality committee, assurance committee going forward, I think is the appropriate NED to be working on the issues of clinical governance. Is everybody happy with that proposal? Are
Yes.
all board members happy with that proposal? Excellent, good. So that's the easy one. The second one comes back to what I would put, and it might not be the case here, I don't know how I would express it, is somebody operating out of their sphere of competence. And this comes back to the issue of appraisal that we discussed earlier. If senior doctors are being regularly and properly appraised, then these issues, and therefore they're getting appropriate continuing professional development, and they are attending the appropriate training courses on a regular basis so that their knowledge is constantly being updated, then I would have thought that these kind of issues that have arisen here, there are safeguards around it. Maybe the answer is no. But I therefore just want to reiterate that issue that I don't care how senior anybody is, whether you're the chief executive or you're the most junior member of staff as an orderly or whatever. You should have a series of agreed objectives, training plans and development plans, and you should adhere to those constantly, and they should be monitored and evaluated, and that's a supportive way to help people in their employment. And I think we need, and we'll probably do this through, there is going to be a people committee going forward, people and culture, and I think we need to really get into monitoring this and really digging into it on a regular basis to make sure it is not acceptable for either the employee or the employer if people are not taking the appropriate, what I would call continuing professional development as they go forward. So I think that's something that we will ask the People Committee to take responsibility for going forward to make sure that that doesn't happen again. And then the final issue for me is the capacity of HCS to deal with the fallout from all of this. Because I know obviously this is going to go to insurers, will be all over it like a rash. They'll have their own lawyers. The government's lawyers will be involved with it as well. But actually this comes back, you're going to have to do quite a few audits, and actually the whole issue of clinical governance needs some serious boost in the organisation. So Chris, this is really one for you about has HCS really got the capacity at present to deal with the fallout from all of this? And if not, perhaps we could have something coming back to the board, in the not too distant future, probably in the next couple of months, which would actually say these are the capacity issues that fall out from all of this, and this is how we're going to address it, because this will generate a lot of work. And that work needs to be accommodated whilst the people of Jersey are getting a proper service as well in terms of their healthcare, without everybody being diverted off dealing with a backward-looking issue rather than their forward-looking health needs.
Yeah, I agree. This is, and quite rightly, has consumed a great deal of capacity, obviously both clinical and managerial, and a big thank you to Adrian Noon, who's been leading clinically on this. We have and it says in our report we received £1.3 million from the Treasury this or last year to support what we needed to do, and that's largely the costs of external consultants, medical consultants, specialists coming in reviewing those 2,500 patients. We've also put forward a business case to the Treasury for this year, seeking further resource, the recognition of the need for capacity. Obviously the legal capacity in the government law office is well briefed and understands what is required, and they are considering the detail of what might be necessary or will be necessary as regards to the compensation process. So definitely a cost there to Jersey as regards to ultimate compensation, but we have put in a business case to get additional resources, but that's purely to manage the rheumatology. I think you're right about our capacity to address clinical governance more widely and at pace. We have limited capacity, we have limited resource, you know, there is significant pressure on the budgets. I have made it always very clear, and there is a paper on the government website that I think, and did we bring it to the board? I can't remember, Steve, about my review of management capacity. If you haven't read it, please go on the government website. It's there because I don't want to talk about it here. But we have limited capacity, despite what the rumours are about too many managers. There is a limit to what we can do. As we improve clinical governance, I would say it's inevitable that we will find more things. Now, as Patrick said, that we're not expecting to see something as dramatic as this, but we will find things, because as governance improves, as we get more evidence, we will find things that will require again increased capacity. We've seen with the maternity improvement plan, for example, that has required a great deal of dedicated capacity. Now, we're very pleased that we now have a new director of midwifery, which is a huge step forward, a substantive director of midwifery that was recruited or started very recently. That does bring some capacity, but everything that we will find will require both clinical and managerial time. So I think the board is right around that, and there is a risk to that because there is clearly not much money around to support this. But I go back to that point I made about the cost of not having good clinical governance is far less or far greater than the cost of having good clinical governance, and I think we will see that through the cost to the island of the compensation that will be required to deal with this issue.
And what we need is for clinical governance not to be seen as a bureaucratic burden, but a safety essential. And that's where we need to be as an organisation, rather than it's all bureaucracy. It's actually about people's safety and not harming individuals. And that's the culture we need to have as an organisation going forward. So I think on this basis, is everybody happy that we've covered the issues that need to be covered? Patrick, do you want to come back?
Just coming back on the issues that you raised around appraisal, just to provide assurance. Late last year we had a review, and Chris alluded to it in his report, from the South West higher level responsible officers group, who made recommendations which we have accepted and will implement. The role of responsible for a suitable person, as it's called, will come under my responsibility as from the 1st of March, and we're in a very advanced stage of discussions with an outside organisation as to how they will support us with that, because up to now within secondary care, appraisals have been done on island between colleagues, but we'll move to a system where half the appraisals will be from off island and half on. We're looking at the number of appraisals that people do, because there have probably been too few, and it will involve quality assurance around the standards of appraisals being done moving forward. And as Chris said, we're expecting for the GMC to audit our appraisals later in the year. So we are working very hard. Hopefully by next board I can perhaps update us to who it is we'll be working with. But for
That's good to hear, thank you.
the other thing I just wondered whether Adrian might, in terms of assurance around the competency.
Just before you do, Adrian, Claire wants to come back in, and then
just a quickie, Patrick. I'd be very careful about making. Can you hear? Is this on? Making appraisal a performance management because appraisals should not be there to pick up poor performance unless it's a management appraisal. I'm sure you don't mean, because this came up last time, the last board, and I'm just concerned that if you're trying to use appraisal to pick up an appalling prescribing, it's got to be audit, quality assurance, adherence to nice guidelines and numbers of complaints. That's where, not with the individual, but with the organisation.
No, absolutely. I mean, I was just to make the point that have been raised around appraisal that we are.
I think just for the public, because it is sometimes difficult to understand what doctor appraisal is compared to perhaps what general public, the appraisal system is. It is a very specific process that isn't, as Claire said, about when I get appraised by my boss, I expect them to pick up where I've not delivered on things, where I've failed my objectives, that would be, to me, that's what appraisal is, and that's not what it is in medicine, both here and across the National Health Service. It is a different type of process. So I think it's always sometimes difficult for non-health people to comprehend the enormous difference between performance management and appraisal, because they are very different things.
I personally think it's a different thing as well, and generally, because frankly, a line manager should be dealing with performance on a daily basis, not annually. And actually, appraisal is about development of the individual as an employee, whether it's in terms of improvement or actually a high flyer. It's that. So I think it's. We all need to keep that in mind about appraisal, but a good point anyway that you've made, that there's a very specific issue around that. But have we got to where we need to get to? Sorry, do you want to come in, Adrian?
Sorry, I'm just going to say, I'm the medical director of primary care as well, and from an appraisal point of view, clearly general practice has been doing it very differently for quite a long time. I'm a GP by background, and so I think there's lots of lessons that we can learn in Jersey about how we do appraisals in primary care, which is part of what we're engaging in, to look at a new appraisal system so that it is supportive and it is educational and it is quality checking the work that the doctor's doing.
Yeah, that sounds brilliant. So, do you want to come in, Bill?
Yeah.
Your maiden speech.
Hi. Can everybody hear me okay at the back? Okay. So, as a relative newcomer, but to try and move forward, to help with the way forward learning lessons. So my experience has been that it's very important to establish terms of reference, to scope out, both from a clinical as well as a corporate services managerial support, because the two issues are slightly different, but they're joined at the hip. And I think to support what Chris and Patrick are saying, that one of the early activities is finding out, before we rush into whether or not we want to import any additional resources in, is to see what skills we have, what capacity we've got to add to the agenda of what needs to be covered. There's also a question of what simple things we can do that don't confuse the clinical review of what's happened, which is from a cultural point of view, from a staff engagement point of view, from an assurance point of view at basic levels, which is how good is the induction? Where do we make our statement about what our duty of candor is? Basic checks and balances. So if we can identify as part of the lessons reviewed moving forward is what are, in basic terms, what's the low-hanging fruit that we can actually start making progress on to assure the public of Jersey that we are actually making traction on it, then the more difficult things, or the more complex things I should say, we can identify that and put a implementation plan together, which I think is what you're talking about. But from a HR point of view, from a workforce, I'm sure Steve and I and Cheryl are here to support and to play our part in any way we can define what that scope is. More than happy to.
Brilliant, thank you, that's very supportive, thank you. So I think we have come to the end of that item as a board. In terms of coming back, so Claire's going to be the NED who oversees this. I do think that we need to see regular progress reports around the recommendations and the actions.
Yes.
So, Chris, if you could take that away and determine with the chair, you know, how regular that needs to be, I think that would be really helpful. And with Claire as well as the relevant NED. So thank you for that. It is a difficult issue. It will continue to be difficult going forward. But when you reach a nadir, you can only go one way, and it's upwards. So I think we're all committed to going upwards from here. And that's what we've all got to do, and that's what people deserve. That's 100% what the public deserves. So let's really commit to that collectively. So on that basis, I think we are now at the time for any questions from members of the public. Nobody did put their hand up while we were in the middle of the discussion. Are there any questions from members of the public? The lady at the back, if you'd like to stand up and say who you are.
I'm Alex. I'm a journalist at ITV Channel, also a taxpayer though, so that's why I really wanted to ask this question. You mentioned your request for more money with regards to potential compensation. How much is that potentially likely to be? Do you have any idea?
The request for funding is from HCS is around the ongoing sort of clinical costs and sort of managerial costs of making things better. The issue of compensation is something for obviously the law office. It's not something I'm an expert in, and that's why we're using the government lawyers to work on that. So it's not something I can assess, but there will be an assessment, I guess, that our insurers and our law office will make on the wider issue of compensation. So the money we're asking for is about ongoing implementation of the improvements that we need to make.
And was there an additional request on that, or is this second request after the 1.3 million?
Yes, so this is a second request. So 1.3 is what we spent last year in managing these reviews. I say largely on doctors to ensure that our patients were safe and they were on the right treatments and being prescribed the right drugs. And that, so the next amount of money is to continue with the work that we need to do. As Adrian said, there are costs to the final audit around deceased patients, and that again will be a clinical cost that we need to fund as well. Again, to assure ourselves in that area. So there are ongoing costs, but these are not the costs of compensation, which is a separate issue.
Is there a total on that secondary?
For putting aside compensation, yes. It's around another £1 million we think we'll be spending.
So a total of 2.3 roughly?
Yes, we believe so.
Okay.
Excluding compensation.
Yeah.
Yes. No, we can do other questions as well, but if there are questions, or any more questions on rheumatology before we move on. Yeah, sorry. Yeah.
Just one for Dr. Adrian. Would it be the Royal College of Physicians that will do that final review into the deaths of the patients?
So the way that we will do that is we will audit the patients who have deceased using the rheumatology audit tool that we've now been using for a year, and look at the rheumatology care, and if we then need to look at them from what's called a medical learning review, which is an international structure for looking at deceased patients and looking at the care that they receive. Then if we have concerns at the end of that, we would then need to decide what we're going to do with those patients. So it would initially be an internal screening tool to look at the deceased patients, and then if we find things that we need to take further action on, then we'll need to speak to the relevant people about that.
So an internal review initially. Thank you.
Okay. Yes, gentlemen.
My name's Andrew Bender. And my question is really to the executive in relation to, I think Claire made the point about the focus is on rheumatology services, but that took a junior doctor to raise concerns. How, as a citizen, because there is great concern in the community that this hasn't or is not currently happening in other specialties across the hospital. And I mean, we've heard, you know, concerning about lack of job plans. Previously, some consultants refused to comply with NICE guidelines. A lot of the work we're doing is excellent. It's going to take several years. There is concern today that people are suffering due to negligence through health. And I'd like to hear what the executive are doing.
Do you want, oh, sorry, if I could start, can you hear me? So I think we've heard today some of the things that we're putting in place, and that was, you know, that's an example of things that we're doing. You know, where we do have concerns, or where concerns are starting to be raised, we will commission future reports, such as the Royal College report, if it's a specific clinical specialty, to assure us that things are right. We will look at, and I think Claire, your point around prescribing is a very good one. You know, that's another way of checking to see whether there's anything that we have concerns about. So when people are speaking up, which they're doing now far more than they've ever done, all those are being absolutely investigated. Can we ever guarantee that services will be completely safe? Well, no health system in the world can guarantee complete safety. Medicine, by its very nature, has risks. We have to get ourselves to a point where we're at the level of assurance, and you as the public at the level of assurance that is 21st century assurance. And many of those issues, so I mentioned the governance, the care group governance meetings. This is where the care group, with challenge from our change team, particularly Professor Kinsey and Cathy Stone, on looking at all the sort of indicators that we have, that whether it suggests that something may or may not go wrong. The data that Anushka was talking about will help, particularly the SPC charts, looking at, for example, pressure damage that's been talked about, or falls. These are all indicators of, you know, falls, pressure damage, things like that are very good indicators of whether nursing practice is good. We need to ensure that medical practice is good. For surgeons, it's reasonably easy, of course, because there's a sort of clear outcome and it's measurable, but that doesn't excuse our physician colleagues, Adrian, because there are measures there as well. So it is about developing that portfolio of indicators that we will bring here so the public can see them, that will provide that assurance. Can we give you assurance totally today? No, we absolutely can't. But there's no indicators at the moment that we've come across that would suggest anything on the scale that we're seeing here in rheumatology, or did see in rheumatology pre-January 2022.
I think the setting up of the subcommittees as well, and one is specifically going to be around clinical governance and safety, which Dr. Garada is going to be chairing. I think that pushes us onto the basis that you would anticipate for a healthcare system. As Chris says, no healthcare system can be 100% certain, but actually it starts creating that culture of good clinical governance and safety, and putting safety at the heart of what everybody does in the hospital. So I think that's really important as well. I know Claire wants to come in, but the other thing I was going to say as well is I also think, you know, you, the public, have got a real role in this as well, because you should be demanding, I mean, you do, you know, this is not in any way me saying that people, you know, are not doing this already, but the public dialogue needs to be about strong and appropriate clinical governance as well, and a demand for that from the professionals who are providing a service to the residents of the island. And I think it's really important that we all collectively, whether we're in the system or out with the system, that we're speaking from the same hymn sheet in terms of that absolute, nothing but the best in terms of safety is good enough. And that's where we should all be really coming from. So, Claire.
Yeah, and just to follow on that, it is important that you're with us on this, because, for example, the reason about adhering to NICE guidelines is sometimes you may go to the doctor and say, I want X, Y, and Z. So I'm just going to pluck an example. I want testosterone patches because I'm having problems, or I want melatonin because I can't sleep. And without nice guidelines, the doctor gives it to you, because the more you badger them, the more you demand, the more. So when nice guidelines come in, it maybe you don't get all of that. And the last board meeting, we talked about operations of I can't remember the term. Limited value, like tonsillectomies and various others, varicose vein operations. I want my varicose vein. So it really is important that the public are with us on this. And what surprises me, unless I'm being told otherwise, is there an equivalent of a board of governors for the hospital? Because I think there needs to be, because these are very sensible people.
There is a patients panel.
Yeah, but there needs to be a board of governors who are the eyes and ears that bring stuff from the inside outside, and maybe part of the review that we do is we need to have a formal board of governors, with the chair of the board of governors being on this board, being on the quality committee, because the people are important, not just the patients, but we want to stop them becoming patients.
I think that's an acutely political issue that would need to be referred to. Yeah, exactly. Patrick, and then final word, because Jean's got a question that she wants to ask about something else. Yeah, no, we'll see what we get to. But Patrick first, and then.
So just going back to your question, so we will be commissioning more reports, but just to be clear that we don't just commission reports when we have a concern. We commission reports as a matter of routine from Royal Colleges, just for them to come in and give us advice on where that service should go to, and are there any concerns that we're not picking up. So we'll continue to do that. And interesting, I won't say the specialty because it's still a conversation, with a Royal College yesterday. One of the points they made was absolutely, when we come to do this, we want to speak to patients and service users. So your involvement in that would be much appreciated.
I think the other thing, of course, is we've got to be clear that not all doctors don't follow guidelines, because that would give the wrong impression. There are many of our clinical colleagues that do and are very committed and passionate about clinical governance. We need to make that consistent across the whole organisation, but it would be wrong to say that, Patrick will know his post-operative infection rate, for example, as an orthopaedic surgeon, and would be able to see, we would be able to see if it was going up and down. So there are areas of practice where we have that assurance, and perhaps areas where we have less. And maternity we often use as an example, because we brought it here. Acute medicine, we know from the Royal College report that came here again that there were concerns about poor care around that, and Adrian is leading on work to improve that aspect. So, but Patrick's right. Reports are not just about when there's a concern raised; it's about providing that ongoing assurance that we're doing what we should be doing, and where we need to improve. Because external peer review, of course, is enormously important.
And I think the number of external links, and certainly for the rheumatology, that service is now very soundly linked in to a bigger unit in the UK.
Right. So, Jean, your turn.
Okay, but if I can go away from rheumatology briefly, and then I'll come back to it. MRI waiting lists. I don't know if I missed this, because sorry, I have been trying to keep up with what's happening in the GPs.
Oh, right, okay. Do tell us.
MRI waiting lists. Claire, can you say, in here it says they're down to 11 weeks. I'm told that that's now back on an upward trajectory, and it's up to 14 weeks. Is that right?
Hi Jean. So when we started the improvement work, the routine wait was at 52 weeks.
Yes.
That was around, I think, October, November time. Pre-Christmas, we got it down to 7. Just as we started January, it was up to about 10 again, and I checked in with the Assistant General Manager yesterday, and we're back at 10. So I think it might have gone up a little bit and then down again. So we were at 10 the other yesterday.
So it's still going in the wrong direction, though.
Well, it should from now on, because we've agreed to more resources.
Yes,
so I'll be very disappointed if it does.
Yeah, I wouldn't say that's the wrong direction when we've got it down from 52 weeks. So we're obviously but we're going again, to keep it, Thank you.
The other thing I wanted to say was, I think most of certainly the turnaround team were aware that I petitioned a while ago for Care Quality Commission inspection, and I know we've moved past that, I know all that, but if it had happened when I first started petitioning for it, then maybe we wouldn't be in the situation we are now with rheumatology. The problem, as has been pointed out, is that we didn't have a qualified rheumatologist on the island, which I think was very poor. It's always because it's not as if it's something that not a lot of people, a lot of people suffer from rheumatism and whatever, so I think that's quite poor. What I discovered when I was doing my petition was that the law concerning hospital inspections and whatever was redrafted in 2014, and at that point, either deliberately or accidentally, the part that said that the hospital must be inspected disappeared. And that law needs to be redrafted, and I will be taking it up with whoever our new Chief Minister is, that's for sure. But that law was redrafted in conjunction with the head of HCS at that time. And I'm not going to name any names, but I think it's very telling that there's now a gap at that table. And I am going to question the appropriateness and the suitability of that person to be sitting on the board, and I will be taking that up as well. So I just want to leave that there.
Yeah. We'll leave that there, thank you.
Thank you.
Thank you for that, yeah. Yes.
Hi, my name's Anne Esterson. I'm just interested to know if any evaluation has been done of the impact of the delays in people getting MRIs. A year's a long time, and the impact on life is quite incredible. So have we reviewed what the impact was and who was responsible for allowing it to go up to a year?
Hi, yes, so we have been looking at that there wasn't historically a harm review policy in place, so that's something that we have developed. We should be getting it to approved sort of in the next month. We do look at all patients with long waits. Obviously they are routine, and I can provide complete assurance on those patients who have urgent and soon need. We've always responded to those. The waits have obviously occurred within the routine cohort, but we continue to, there's a process whereby the clinicians who have triaged patients, they are regularly reviewed, and we've just been developing some of the templates to obviously provide a bit more of a systematic approach, and so we can report on that in a more global sense. But the weights are in, unfortunately, those areas where there is less clinical concern or urgency, but we pick that up with the specialties as part of the weekly process when we review all of our waiting lists with departments. So we do have a process to ensure that people who of their condition changes, we can then change their clinical triage and we bring their appointment forward.
I think just sort of to add to that, of course, the issue of waiting lists and how many people are on a waiting list is, to me, the length of waiting list is less important than the weight on that waiting list. So if there's 1,000 people but you're only waiting a week, then it's the waiting time. So of course there are a number of dynamics around demand and supply. So we talk about fault. Obviously there are a number of issues. One is the demand for a particular service. The other is the level of resource that health has to invest in the resources necessary to bring that down, and that is often workforce capacity, so locum costs, for example, or just more people, substantive people. There's also sort of physical capacity. Do we have enough physical capacity? And then there's a productivity element to that, which we touched on earlier in the board around are our services productive in the way that they work. So a sort of number of dynamics that when you're planning the waiting list reduction program that have a big impact on whether the waiting list is 1 year or 2. So if in health systems where I've been where we've had to close wards because of finances, that that means the waiting list increases, because there's not the resource there to reduce them. So it's all those different dynamics at play about how we manage that. And I think MRI getting down from 52 weeks to 10 or 11 now is an example where we've been able to sort of match finances with productivity, with using equipment more effectively to make that happen. Now clearly if we didn't have the resource to do it, the financial resource, then that wouldn't have happened. So there is a whole range of sort of dynamics. Now if we're in a financial situation where I have to reduce capacity, then waiting lists will go up. But that is a decision, obviously not for me. It's ultimately a political decision about the level of resource that we see being made available for healthcare in Jersey. But we will, as an executive, as a board, as we said earlier, be absolutely focused on reducing waiting times, because we all know how important it is to all of us not to wait and gain access to healthcare quickly, whether that's through the A&E department, whether it's your GP, or whether it's for elective care, diagnostic care, mental health services. When we plan those reductions, it's bringing all those different aspects together to get maximum benefit for patients. That's the important thing.
Okay. So you're a member of the public?
You OB.
Finance was mentioned, so I thought I think it's a perfect example of just building on what Chris is saying, of how the quality and the money comes together. And I think the bringing down the MRI waiting lists is a perfect example of how the doctors and the clinicians have worked with management here to change whatever old practices where waiting lists were going up to 53 weeks was shameful because there wasn't the resource to do anything about it. But what we did working with management and clinicians is actually take a decision to fund it. And that energized the doctors. You would have seen the interviews by the very doctors involved in the media, who have said this is probably the perfect example of the whole department's culture has changed. We feel really energized to do it. Within a 13-week period, they brought the waiting list down from 53 weeks to 7 weeks. That is a commendable thing. The issue now is maintaining that. We have also worked with them. There was the storm in Europe, and therefore scanners went down because of it, and that was partly the reason why some of the waiting started going back up. But from 53 to even what is now 10 is really, really good when you look at the patient benefit that is brought. The money will always be constrained, as Chris quite rightly says. So if there was an unlimited pot of money, of course we could deliver all the services anybody wants on demand. There isn't. And it is not entirely in HCS's control to provide that. And you will hear more about that at the next board meeting, about what the finances are telling us at the end of the year. But nevertheless, I think we should also be able to report on another innovative way of how we maintain these waiting lists and bring them down yet again and fund that without needing to ask Treasury for more money. I can't reveal that right now, but we've been working with our clinicians and management to do that. I wish we could replicate this across all our specialties, because that is what I think turnaround is all about, bringing the quality and the money together. But it's tough. It's really, really tough. That's just one example.
Tough but successful, and I think at that point and on that positive note, that's an appropriate time to bring the meeting to an end. We're 5 minutes over, I apologise for that, but thank you to everybody for your interest today and for coming today, for your contributions, and have a good rest of the day, and we'll see you in a month's time.
Later on.